Doctor, we are live now.
Good evening, everyone. Young Ophthalmologist Society of India proudly presents the Naadi Season 3, an international online case presentation competition. Be inspired from this Tirkural, Noi Nadi, Noi Mudal Nadi, Aditanikum Vai Nadi, Vaipet Sale. What is it like? We have to diagnose the illness and trace its cause and seek the problem remedy and apply it with skill. So we thank the YOSI president and secretary for giving opportunity to conduct this competition, and we thank all the 15 countries who are being part of it, which would have not been possible without Dr. Prasanna. First, we welcome the first judge, Dr. Deep Shekhar Das. He is assistant professor at AIMS, New Delhi. Next, we have Dr. Gunjan. She is a consultant in strabismus, occuloplasty, and neuro-ophthalmology services. She has trained in AIMS, New Delhi. Next, we have Dr. Gautam. He is trained from Jitmat Pondicherry. Next panel, we have Dr. Sujit. He is head of department at Yashoda Eye Institute in Telangana. Over to Dr. Prasanna to introduce the other panels.
Yeah, can you just keep going? Yeah, thank you, Karthik. I would like to call upon again. I'm saying as an ophthalmologist sister, Dr. Shruti ma'am, who's always been there for YOSI, a dynamic pediatric ophthalmologist from Chennai. Can we have the next slide, Karthik? Yeah, and Dr. Koma Shweta, again an assistant professor, consultant, Sri Sai Netralayam, Chennai. Welcome, ma'am. Who's an ex-consultant from Shankara Eye Hospital and has published many papers. And also Dr. Ayushi Agarwal, who's also one of our dynamic executives who has supported a lot in this Naadi by spreading the word with the residents. Welcome to all the panelists of today. And yeah. And over to Karthi. So myself, Dr. Karthi, you can move Karthi. So myself, Dr. Prasanna Venkatesh. Can we have the next slide, Karthi? And Dr. Pranesh Ravi, again, one of the dynamic PWG members, a cornea consultant, and who's also heading a branch on itself at the Eye Foundation, Huzur. Can we have the next slide? And Dr. Karthikeyan. So we three are part of the organizing team, and we three will be moderating the session for today's evening. And before we just start, can you just stop the screen, Karthi? I would like to just talk on Naadi, how we started from humble beginnings. If we can just stop the screen share for this. Yeah, we also like to invite Naranjan. Again, Naranjan is another organizing person behind who has worked tirelessly for Naadi Season 3, who's again one of the executive members, editor of YOSI, and also a co-editor of TNOA Times. Can we have the next two slides as well, Karthik? And Dr. Sameer Chaudhary, another executive member of YOSI, and Dr. Aditya Varman, another executive member of YOSI and TNOA as well, who's very active in both the forums. So with that, just a quick word on Naadi and how we actually started from humble beginnings. So Naadi, that you can see my screen here. So this was one of the first ever competitions that was the brainchild of Dr. Karthikeyan Mahalingam. We had this in 2023, 2 years back in the month of March. And this was one of the magnum opus events. That time we had around 25 plus registrations supported by Dr. Sonal Kalia ma'am, Digvijay sir, Devakant sir, Karan, and whole team of YOSI at that point in time. And we four came together under the leadership of Dr. Karthikeyan Mahalingam for season 1. And these were the 9 winners that we had that time, along with Dr. Nirmal sir being the guest of honor for last year. And for this year, we have 3 days and we have roped in international faculties as well. 15 countries are part of it, as you can see in the Zoom backdrop that we just shared, which all of us have the program book as well. 15 countries, and we have close to 9 hours of academic sessions there in the pipeline, and looking forward to having, without much delay, starting the event, handing it back over to my co-moderators, Karthi and Pranesh.
Yeah. Without delay, I think we can start. Thanks, Prasanna. Without delay, we can start with the first participant, Dr. Gunal. You can start your.
Yes, I am.
Yeah.
Okay.
I think judges. I think judges and panel are ready.
Just check the judges are ready. Double check, Karthi, and once they are.
Yeah. Dr. Deep, Dr. Gunjan, and Dr.
I'm
Gautam.
fine.
Yeah.
Sir, I'm
Yes, I'm ready.
Yeah, I
Perfect.
think we'll take 1 or 2 questions only to for considering the time limit. Yeah. I think you can start, Doctor. Timer is ready.
Greeting from Land of Fire, Baku. Good luck to all the delegates and all the presents for the case compositions. My name is Gülüm Mehmetova. This is my case presentations. Our patient is the a 20 years old male who came to us with a sudden vision loss in the right eye, accompanied by mild pain for the past 2-3 days. Visual acuity was right eye 6/600, left eye 6/6. Intraocular pressure was normal in the both eyes. The entire segment was normal, but the right pupil reaction to light was weak and the ray PD test was positive. The Ishihara color test could not be performed in the right eye because of poor vision. Color from this photograph of the right eye revealed marked optic disc swelling, a macular star pattern, and peripapillar edema. The left eye was normal. Flash VPD in the right eye showed normal P2 latence, but amplitude was moderately reduced. The left eye showed normal latence and amplitude. These findings indicated optic nerve dysfunction in the right eye. Possible causes considered included cat scratch disease, Bartonella Hensel, syphilis, toxoplasmosis, Lyme disease, leptospirosis, and toxocariasis. Contrast enhanced MRI of the brain and spine was normal. Chest X-ray was normal. All laboratory tests were within normal limits. Confirmed TB and Bartonella tests were negative. These results supported the idiopathic natures of the disease. Additional test ELISA test was negative. Cytomegalovirus ICG was positive. This indicated a past infection. No pathologic changes were detected on the MRI. Anti-TB, anti-Treponema pallidum, and anti-HIV, anti-human immunodeficient virus were negative. And treatment, topical therapy included prednisolone acetate 1% started 12 times per day and tapered gradually. Symptomatic treatment consisted of methylprednisolone intravenous therapy 1 gram per day for 5 days are under neurologist supervision, followed by oral methylprednisolone 64 milligrams per day tapered slowly, omeprazole 20 milligrams daily, Burosporin 25 milligrams during pulse therapy, and Osiart 800 milligrams daily is supportive treatment. Follow up 5 days. After 5 days, visual acuity improved to 6 hour 26. Fans showed mild reduction in disc edema. Star pattern still present. After 50 days, best corrected visual acuity improved to 6 hours 25. Disc edema markedly reduced. After 35 days, best corrected visual acuity improved to 6 hours 19. Only forest macular exudative remained. And after 3 months, best corrected visual acuity improved to 6 over 12. Disc and macular for almost completely normal. Left eye remained 6 over 6. Leber's idiopathic stellate neuroretinitis were first described by Theodor Leber in 1916. It is a rare optic nerve disorder characterized by optic disc swelling and macular star. About half of cases are idiopathic and the rest are infection-related. Common causes included Bartonella, syphilis, toxoplasma, Lyme, leptospira, and toxocaria. Symptoms include sudden vision loss, loss of color, and constant contrast sensitivity and metamorphopsia. The disease is usually self-limited with good prognosis. Leber's idiopathic stellate retinitis is a rare, benign, and self-resolving condition. With prompt steroid therapy and close monitoring, excellent visual recovery can be achieved. Thank you for your attention.
Okay. Very nice presentation, Dr. Gunal. Can we have some comments from the judges, Dr. Deep or Dr. Gunjan, who is available?
It's a
Yes.
nice. It was very nicely presented, doctor. But the issue is, like, I have one question. Did you perform OCT, or you don't usually do OCT in such patients?
No, I have not. We didn't do OCT for this case.
Okay. Okay, and usually ECR can be performed even in cases of poor vision as well to certain degree. But anyways, it's a very nice presentation. Okay.
And what was the follow-up of this patient? How long was the follow-up? Was there any recurrence in the course?
After first is after 5 days and 15 days and 35 days and 3 months. After 3 months, best corrected visual acuity improved to 6/12. Disc and macula were almost completely normal.
Okay. After 3 months, you don't have that follow-up, right?
Yes.
Dr.
Okay.
Sweta, you have any comments?
Yeah, I just want to ask one thing. Good presentation, doctor. So you didn't mention anything about anterior vitreous phase cells. That is very important in cases of neuroretinitis.
Can you reply more? I don't understand you.
Anterior vitreous phase cells, which is like very important in case of a neuroretinitis. So that is one thing I wanted to add.
No.
Okay. I think you can stop your slide share.
Yes.
Yeah.
Yeah, Dr. Gunal, you can stop your screen sharing.
Thank you. Thank you.
Yeah, it's a wonderful presentation, Dr. Gunal. Thank you for joining us all the way from TROS, and thank you, and convey our regards to the whole team of TROS as well.
Dr. Aitan, I think you can start your slide share.
Yes, I'm here.
Yeah. Dr. Gunal, you need to stop your screen sharing.
Okay.
Dr. Gunal, can you?
I stop at this.
Okay. Manjula, yeah, thank you so much. Yeah, Dr. Aitan, yeah, fine. Now you can start your presentation.
Okay, hello, greetings from Baku, and good luck to all presenters. I'm Ayten Ibadova, second year resident, and this is my case presentation. Today I will be presenting a case of a 12-year-old male patient with acute swelling and sorry.
If your slides are not moving, just
Okay, sorry.
cursor inside the slides and click it. It will move. Yeah.
Okay, acute swelling and redness of eyelids. He had a mild fever, 37 at 38 degree. He also complained of double vision diplopia and decreased visual acuity in the left eye. Past history, he had no history of nasal abnormalities, any systemic illness or trauma, and also no relevant family history, no non-drug allergy. Physical examination, we can see in the video, left eye, restricted eye movements, swelling of eyelids, especially temporal side, conjunctival chemosis, and exophthalmos, we see here. Examination finding all parameters in right eye were normal, but in left eye, visual acuity decreased was 30%. Extraocular movements were forcibly restricted and conjunctival chemotic, but other parameters were normal. Investigation, we performed CT and MRI imaging with laboratory, along with laboratory blood tests. CT imaging showed we see here exophthalmos, approximately 3 millimeter, and infiltrative swelling of fatty tissue extending from the left periorbital region to the retrobulbar area. And contrast MRI findings show that 30 and 27 millimeters heterogeneous infiltrative area revolving postseptal and preseptal regions extending into extracorneal space. Laboratory blood tests showed elevated ESR and herpes simplex virus and cytomegalovirus serology test positive, and other parameters were normal. Liver function test, liver infection test, inflammatory and immunological markers, and metabolite were within normal limits. Management, we firstly start antiviral agents valaciclovir twice a day, 6 days. Antibiotics, both intravenous and local. Intravenous ceftazidime 7 days and metronidazole 4 days, and local as like eye ointment, ciprofloxacin 2 weeks and levofloxacin 2 weeks. Steroids with dexamethasone started with 6 milligram and reduced according to the schedule 2 weeks and intravenous. And anti-inflammatory ibuprofen for inflammatory and fever 10 days twice a day. Probiotics due to long-term antibiotic use, and eye-lowering agents due to long-term steroid use. Result and outcome after treatment, a patient had a significant improvement. Visual acuity increased from 30% to 80%, and eye movements full in all gaze, and swelling and hemosis completely resolved. Final diagnosis, pediatric acute dacryoadenitis, left-sided viral etiology associated with herpes simplex virus and cytomegalovirus. The differential diagnosis, we thought about several diagnoses. Firstly, as infectious inflammation, cellulitis, bacterial and fungal, lacrimal gland tumors, lacrimal gland abscess. But as non-infectious orbital inflammation, rhabdomyosarcoma, Wegener's granulomatosis, and idiopathic orbital inflammatory syndrome. Thank you for your attention.
Thank you, Dr. Aitan. Can you have quick comments from Dr. Gunjan?
Dr. Aitan, can you stop sharing your screen?
Yes, it was a nice case. My only query is, how did you decide which antibiotics have to be given? Was any culture sensitivity done? How was it the empirical therapy that is being given to all your patients?
Dr. Aitan?
Yeah, could you repeat one more time, please?
Yes, sure. How did you decide about the antibiotic use? Was any culture sensitivity done? Is it the empirical therapy which is being given to all your patients?
Okay.
I don't understand you.
I'm just asking, how did you decide which antibiotics have to be used? Was any culture sensitivity done for the same?
No, we don't have any culture, but we use systemically. Eye ointment and yes, and intravenous and eye ointment, like eye ointment.
Okay.
But no, we don't have any culture.
Thank you.
Thanks.
Thank you, Dr. Gunjan and Dr. Aitan. You can stop your slide share. We will call upon Dr. Saima. Dr. Aitan, you can stop. Yeah, thank you. Dr. Saima, are you online?
Yes, I'm online.
Yeah. Yeah, you can start your screen. You are audible. You are audible.
Am I audible?
Yeah, you are audible.
Yeah,
Okay, okay. I'm going to share.
Yeah.
yes, yes, you're audible.
You can click the slide share button. Yeah. Slideshow.
Sludge. Which one is this? Button. Slideshow. From beginning. Okay, am I audible?
Yeah, you're audible. You can start.
Good evening, my respected judges and dear audience. I'm Dr. Saabinte Shams, working as a long-term fellow pediatric ophthalmology and strabismus. And I'm going to share a topic about accommodative access, where eye strain is a mystery. My particulars of the patient named X, 9-year-old male, hailing from Munshiganj, came into our hospital with the complaints of decreased vision for last 3 to 4 months, both distance and near, along with headache and eye ache for during reading time for same duration. On examination of the vision, visual acuity unaided for right eye and left eye 6/60 distance and N6 for both eye near. Dry retinoscopy reveals -4.50 diopter spherical with no improvement of vision. On pinhole 6/9 was both eye. And visual acuity unaided after instilling cycloplegic eye drop, the visual acuity was both eye for 6/18 and with the +1.50 diopter spherical, visual acuity was improved to 6/12 in both eye. And after doing the binocular evaluation, the ocular motility was full in all gaze. Cover uncover test reveals 8 prism diopter isophoria for distance and 12 prism diopter isophoria for near. Near point of convergence 6 cm. Amplitude of accommodation 16.5 diopter. Accommodative facility was difficulty clearing in both and plus minus lens. And MEM or monocular estimated method reveals slit. Slit lamp and fundus was normal in both eyes. So my clinical diagnosis was accommodative excess or pseudomyopia of both eyes. And we managed the patient. We gave 2 separate spectacles for distance and near vision, along with atropine 1% eye drop daily for 1 month. And the final prescription of the spectacle was +1.50 diopter spherical with visual acuity 6/12 for distance and with +2.50 diopter spherical with N5 for near vision. And the patient was advised to use the atropine drop for 1 month and then stop for 1 month and follow up in post-cycloplegic state after 1 month. And on the day of first follow-up, the visual acuity was improved to 6/9 unaided and with +7.75 diopter spherical, visual acuity was 6/6 partial for both distance and N5 at near. And the patient was advised for second follow-up after 3 months. So now discussion, the accommodative excess occur when the eye exert greater accommodation power than necessary for given stimulus at a particular distance or relaxed accommodation. The common causes actually extended near work is the key for development of accommodative excess. Usually young individual with hyperopia, young males, uncarried astigmatism or presbyopia. So thorough evaluation is crucial for diagnosis the accommodative excess. So we have to do visual acuity, cycloplegic diffraction, do ocular motility, do cover uncover test, do prism cover test. And for doing binocular evaluation, near point of convergence, near point of accommodation test, and all the videos are taken with the permission of patient's parents, and doing accommodative facility with a plus and minus lens. This MEM retinoscopy. And the treatment options usually optical correction with cycloplegic diffraction. Pharmacological therapy include atropine 1% eye drop to relax the ciliary spasm or accommodative spasm, and then after vision therapy. And the prognosis for accommodative excess is usually good with early diagnosis and treatment. So my take-home message is it is a prevalent accommodation abnormality in child and adults, and the main therapeutic goal is to provide patient with good vergence and accommodative facility, and appropriate refractive error correction should be prescribed, and patient counseling is very important for this case. Thanks to all for patient sharing.
Thank you, Dr. Saima. Well in time. We'd like to hear the question from Dr. Shruti. Madam.
Hello. So very nice presentation, Dr. Saima.
Thank you.
Oh, that is the music for stopping, I suppose. So my question is, did you notice any pupillary meiosis, number one? Number two, what was the follow-up? Did you do any vision therapy for the patient? because usually these kind of things just with atropine may not, they may have a rebound. So usually we recommend vision therapy. And the third thing was whether you asked for any inciting factors such as excessive near work or screen time.
Okay, thank you for your question. The first answer of the question is there was no pupillary hemolysis. Pupillary reaction was around regular reacting normal.
Okay.
Okay, and second question was vision therapy along with atropine 1% eye drop. Actually, the first follow-up after giving the atropine 1% after 45 days, the visual acuity is improved from 618 to 66 partial. So vision therapy, we did not prescribe for that session. And we gave follow-up, second follow-up for after 3 months, and the patient will come next January 2026. Then we can evaluate thoroughly. Then she
Yeah,
could
you can
get
consider
any
vision therapy to kind
vision
of
therapy.
stabilize
But
the.
we have planned to do vision therapy.
Very nice. That's great. And as regards the triggering factors, did you ask?
Triggering factor extra near work, as he was a child with 9 years old, madrasa student. And in Islamic religion, they have to do extra near work for 4 hours, 6 hours, and prolonged time for.
Excellent, excellent, fantastic. Thank you.
Thank you, madam. Thank you. Can we have the next candidate, Dr. Delgar Zulpak from Mongolia?
Hello, everyone. Can you hear me?
Yeah, I can hear you. Please.
Okay,
Can you share your
my
slides?
Yeah, I can do that. Thank you. Okay, can you see my screen?
Yes, the screen is visible, madam. Yes, perfect.
Okay, that's great.
Perfect.
Okay, so good morning, afternoon, and evening to everyone all. I'm Dr. Dikrit Lutbat, a glaucoma fellow at the site for all and one of the participants from the Mongolian Young Ophthalmology Society. Today, I'll be sharing a rare yet specific case titled This, and we're gonna start. Our patient is a 59-year-old Mongolian woman presenting with 6 days of painless redness, tearing, and blurred vision in her right eye. The lack of pain was striking from the first start, so she tried lubricants with no improvement. Her symptoms progressed gradually, and 3 months earlier, she had undergone therapy for right CPA, cerebellopontine angle acoustic neuroma. We know is vestibular schwannoma as well. So this background raised early suspicion for neurotrophic keratitis. On examination, she had reduced, on the physical examination, she had reduced hearing on the right ear and decreased facial sensation in the right side of the face. And her other vital examinations were normal. And this is the eye picture, as well as some ophthalmologic examination. The right eye visual acuity was counting finger at 1 meter, and we can clearly see there's a 7x4 millimeter central stromal ulcer with some hypopyon underneath. Also, investigations were done. Corneal scraping confirmed that there was this Staphylococcus epidermis and Staphylococcus aureus detected, and both were quite effective, sensitive to fluoroquinolone drugs. And previous MRI results she showed some cerebellopontine acoustic neuroma in the right side. So we have our problem list here. So our final impression was neurotrophic keratitis secondary to CPA angle schwannoma, and it was a stage 2 to 3. And also there was secondary bacterial infection as well. So what we did was did the very intensive antibiotic treatments with some preservative-free artificial tears, as well as cycloplegic drops to prevent some synechia. And within 5 days, we performed lateral tarsorrhaphy surgery, as well as on the follow-up. In the day 7, also margins were contracting, and on the day 38, the complete epithelial healing occurred with the final visual acuity of 6/12. And so here is my discussion table. So corneal nerve supply is not only just sensation, it's also trophic nourishing support. So from the trigeminal nerve supply, if you lose the if we have some lesion in that area, we could use epithelial cell mitosis as well as metabolism slowdown. And it causes decreased corneal sensitivity and decreased healing capacity, which increase the risk of epithelial breakdown. So our clinical red flag was corneal numbness, even though the ulceration was very big. So you can see my slides in here. Neurotrophic keratitis is quite rare, but it does happen. And what we've learned from this case is painless corneal ulcers speaks volumes if you're trained to listen to them. Also, multidisciplinary care is very crucial in this kind of environment. So thank you all.
Thank you very much, Dr. Delgarzal. Now we have Dr. Gautam from Jupner. Can you ask your questions to the contestant, please?
Hi, good evening.
Good
Are you aware of any recombinant human growth factor drops that can be used in such cases, which is
Yes,
stored in?
I've read about that article, and it seemed that it seemed very useful in these cases. But
Yeah.
in our country, Mongolia, we don't have any access to that treatment, and it is not really cheap,
Yeah,
as
fine.
you may
Actually,
say.
in India also it's not available. I guess it's Senagermin drops can be used in such cases. It's
That's
approved in
great.
US and UK.
Also, it was recommended that we could use some amniotic membrane to cover it because
Yes,
there was
yes.
some bacterial infection. We can use bandage contact lens, but in our case, we Mongolia also doesn't have any eye banking, so that was a difficult call.
Okay, thank you.
Thank you.
Thank you, Dr. Delgarzal Bath. It was a nice presentation, Doctor. And for our next presentation, we have Dr. Shafiq Tanveer. Doctor, from Pakistan, can you share your slides, Doctor, please? Yeah, your slides are visible, Doctor. You can go to presenters mode. Yes, you can start your presentation. Over to you, Doctor. You're audible, Doctor. Hello. Your voice is a bit muffled, Doctor. Hello, am I audible?
Ganesh, you are audible. There is an issue with Dr. Shariq's side.
Shafiq.
Dr. Shariq, can you
Sure.
start, Dr. Shariq?
Dr. Shafiq, would you want to get it sorted or we need some time? We can go to the next presentation, then come back to you. Would that be okay with you, Doctor? Yeah, okay.
It's more like a muffled voice, Dr. Shafiq.
Can you hear me now?
Yeah, now better. Yes.
Yes.
Okay. Can I start now?
Yeah, please start.
Yes, please.
Good evening. My name is Shafiq Tanveer. I'm from Pakistan, and today I'm going to present a case report on rare presentation of retinoblastoma, which presented as orbital cellulitis in a 2-month-old infant. So this is the picture of a poor baby that we received, and it was indeed a very big surprise to us. We received a 2-month-old infant who was brought to outpatient department with a red swollen eyelid. The parents reported sticky discharge and slight proptosis. We, like everyone else, we also suspected infection in this patient. There was no excessive watering or photophobia. The patient was full-term, normal vaginal delivery and uneventful birth history. No prior eye discharge was there, but the patient reported recent fever, flu, and chest infection, which also pointed out towards infectious etiology. So our initial clinical suspicion was orbital cellulitis, and so the patient was started on broad-spectrum antibiotics. On examination, we could see left eye proptosis, conjunctival chemosis, hazy cornea with indistinct anterior segment details. There was white pupillary reflex also seen. We started the patient on broad spectrum antibiotics, but despite antibiotics, the swelling did not improve. So we performed further imaging, and what we saw was hypointense retinal-based mass in the vitreous cavity, which also involved sclera at 4 o'clock position. To augment this investigation, we further performed CT scan, and what we saw was a very big surprise. We could see intraocular dense calcification in the patient's eye. Based on these investigations, the patient was diagnosed as group E retinoblastoma with scleral extension, and patient was scheduled for 2 cycles of chemotherapy with a plan of subsequent enucleation and genetic counseling of the patients for further early management and early examination of the other children. Retinoblastoma is most common intraocular cancer in children, usually present as leukocoria and strabismus. It rarely mimics orbital cellulitis in less than 5% of the cases. This necrotic tumor can usually cause inflammation in the eye, which can hide the underlying tumor, and early diagnosis and treatment improve the prognosis. These are the common presentation of retinoblastoma, which you can see that leukocoria and strabismus are the most common ones. Retinoblastoma typically present as leukocoria and strabismus. Pediatric orbital inflammation unresponsive to antibiotics should raise the suspicion for malignancy. Persistent ocular findings in this case prompted advanced images revealing a retinal mass with periscleral and perioptic extension. These are some of the case reports that have already been published on retinoblastoma mimicking orbital cellulitis, and there are very few cases which present as this. The take-home message from this case report is that in infants, persistent ocular inflammation that does not respond to treatment should always raise suspicion of retinoblastoma, and early imaging and timely intervention are life-saving. Unfortunately, in our case, because the tumor has already extended a lot, we could not save the life of the patient. These are some of my references, and with this, I thank you all.
Thank you. Thank you very much, Dr. Shafiq. It was a great presentation. Can I have a few words from the judges, Dr. Deep Shekhar? Sir, can you?
Hi, Dr. Shafiq. It was a nice presentation. Just a question: do you have ultrasound in your setting? Because as per the recent literature, like of all the investigation or imaging modalities which are being used for retinoblastoma screening, the maximum or the highest sensitivity still goes with just pure ocular ultrasound. It's not expensive as MRI or CT.
Yes, sir. Yes, sir. B-scan ultrasound is available, and we usually perform B-scan as a first-line modality for all the children presenting with tumor. But in this case, number one, we were not. In this case, number one, we were not suspecting tumor in the first place, and secondly, as the child was very small, we could not perform ultrasound. So basically, the CT scan and MRI were performed when the child was sedated or under anesthesia. So that was an easy call as compared to B-scan ultrasound.
Okay. Usually, in case of children, also it is usually done for all retinoblastoma. That's what usually the overall global consensus is. Anyways, very good
Yes,
presentation.
sir.
Okay.
Thank you. Thank you.
So nice presentation, Doctor. For the next presentation, we have Dr. K. Niruthan from Sri Lanka on intraocular tumor. Dr. Niruthan?
Yeah, can you hear me?
Yeah, I can hear you. Your slides are visible, Doctor. You can start your presentation. All the best.
Okay. Thanks a lot. This is a case report which I'm sharing with which I manage with my trainer, Dr. Mangala Thanapala from the Eye Hospital, Colombo. So this is a 15-year-old girl who presented with gradual reduction in vision for 6 months duration with no other eye symptoms. She was systemically well and there was no family history as well. On examination, she had a 660 vision in the right eye. And as you can see in the picture, the clear lens is pushed nasally by a large brownish mass arising from probably the ciliary body, extending to the visual axis, and it was mildly translucent to the transillumination. The visualized retina and the disc and macula were normal. We didn't have any UBM, so we went on directly for the MRI, which showed a well-defined intraocular soft tissue mass in the right eye, which was fairly a large one from the ciliary body, and it was high density to T1 and low in T2, and homogeneous post-contrast enhancements also noted. Their suspicion was of a melanoma, but we did a systemic evaluation to look for other possible causes, which was normal, and we did also FNAB, and which was inconclusive. So pediatric intraocular tumors, it can be malignant or benign, and there are various differential diagnoses to look into. But in our case, our management plan has to depend on whether it's a benign or malignant at first. So it's a 15-year-old Sri Lankan with clinically no evidence of extraocular extensions radiologically and also clinically. And systemic evaluation was negative, and it was a solid lesion by the biopsy. So this is a short video which I have trimmed down to show how we manage it to find out what it is. We have already done the vitrectomy and lensectomy and stabilized the globe with heavy liquids. And we have done a scleral flap. Before that, we have secured the lateral rectus muscle. And our plan was to debulk it and find out how it goes. So we started debulking the tumor, as you can see. It's a whitish tissue, and you can see that once we found the underlying choroidal plane, then to our surprise, that tumor just popped outside without any much of manipulation. So we were able to resect the tumor without any difficulties, but it's easier to say than doing it. So we routinely closed, and we had silicon oil tamponade, and we put a sulcus IO later. So what was it actually? So it was a spindle-shaped cells arranged in fascicles, and it was positive to SMA, and the diagnosis of intraocular leiomyoma was made. It's a very rare, and only 80 cases have been reported so far, and it's more common in females and present in the 3rd to 4th decades, and mostly located in the ciliary body region. They are very difficult to differentiate from a melanotic melanomas because they are similar in radiological appearance. So the management can be based on the clinical presentation. So in our case, it presented as a well-localized tumor. But in the literature, we can see that nearly 41% of the cases were enucleated in suspicion of melanoma. There are various treatment options like to observe, excise, or radiate or enucleate. That depends on the extent of the tumor, how it presents, the age, and all those factors to be considered. So what does this case highlight to us is that choroidal melanomas and leiomyomos are clinically and radiologically indifferent, and high index of clinical suspicion should be needed to salvage the eye. Thank you for listening and giving me this opportunity.
Great presentation, Dr. Niruthan. We'll go next to the judges. I'd like Gunjan madam to ask a few questions to the.
Yeah, so was ultrasound biomicroscopy done for this? Like UBM was done for this patient?
Yeah, we don't have UBM in Sri Lanka actually.
Okay, and how did you close the defect that was created after excising the tumor? You showed a very beautiful video,
So
very nice presentation. So
yeah,
how did you close it?
We didn't do a lamellar scleral excision. We just took a scleral flap, closed the flap again by just suturing it back.
You just sutured
So
it back.
this is the post-op.
Okay.
Yeah, this is the post-op picture that just sutured back.
Yeah.
So the outcome was
ideally,
very nice and
yeah,
had a 6/9 vision after
very
removing the oil
nice.
and placing the
Nice.
lens.
So ideally, a scleral patch graft or amniotic membrane graft, multi-layered, can be helpful in these cases.
Yeah.
So nicely managed. Thank you.
Thank you, Niruthan. Thank you, judges. And really thankful to the international candidates for being with us. Now we move on to our Indian case presenters. To start with, we have Dr. Simran Koshla on choroidal melanoma. Hello, Dr. Simran. Can you?
Good evening, everyone. Let's hear out a very interesting case.
Doctor, I'm not able to. One sec. Yeah, your slides also. Yeah, you can make full screen and you can go out, doctor. Yeah.
Good evening, everyone. Let's hear out a very interesting case that started with the benign complaints and then led to the malignant truth. 24-year-old male resident of Ajmer, student by profession, went to the eye OPD on 8th Feb with slight diminution of vision in left eye since 3 months. It was associated with headache and floaters since few months earlier. The patient was apparently asymptomatic 10 months back when he developed slight diminution of vision in the left eye that was marked on the left lateral field, gradual in onset, non-progressive, with no diurnal variation, associated with floaters and headache. There was no history of pain, watering, photophobia, flashes, etc. Patient had no significant systemic and ocular, medical and surgical history, drug intake history or the family history. General examination and the systemic examination was carried out, which was within the normal limits. Ocular examination was carried out that included the extraocular movements, nasal examination, and the anterior segment examination, which was within the normal limits for both the eyes. Best corrected visual acuity was 6/6 in the right eye and 6/9 in the left eye, with IOP of 18 mm Hg in right eye and 21 mm Hg in the left eye. Fundus examination was done using indirect ophthalmoscopy that revealed a solid dark brown lesion in the left eye in superotemporal quadrant with diffuse borders and around 5 disc diameter in size, with overlying vessels and pigmentation and a mild rim of the shifting SRF. Wide field fundus photography was done that was within the normal limits in the right eye and in the left eye that showed a brownish green mass in the peripheral region. Ultrasonography was done where the B scan showed the dome-shaped mass arising from the choroid with homogeneous medium reflectivity, and the A scan showed the positive angle kappa sign. MRI brain with orbit was advised. It showed the lesion on the posterior-superolateral aspect of left eye with hyperintensity on T1 weighted and hypointensity on T2 weighted. OCT showed the choroidal hyperreflectivity with subretinal fluid and the shaggy ellipsoid zone, and the FFA showed the double circulation with a late staining and stippling. Routine investigations were ordered and the liver function tests were done, which were within the normal limits. And the investigations done were USG, abdomen, chest X-ray, and the PET CT that were all within the normal limits. So, based upon the clinical diagnosis and the investigation modalities, choroidal nevus, metastasis, and the hemangioma all were ruled out, and a probable diagnosis of choroidal melanoma was made based upon the fundus finding, A scan, and the B scan finding. This tumor was graded as moderate tumor, and it was T2A N0 M0 stage 2A, and a management plan was prepared using the ophthalmologist, medical oncologist, and the radiation oncologist. Modality of treatment chosen was plaque brachytherapy since the tumor was less than 20 mm in diameter. Salvageable vision was there, and the studies shows that the prognosis is similar as compared to the enucleation for the comparable tumors. So ruthenium-106 plaque was kept for 7 days, and the radiation dose of 80 gray was given to the tumor. Patient was followed up every 2 weekly for 1 month, and then 3 monthly, and then at 6-month interval. So the serial USG showed the largest basal diameter regressing from 11.46 mm at presentation to 10.2 mm at 6-month post brachytherapy. As also evidenced from the fundus photography, there was a regression in the tumor. So by this case, I want to emphasize that never overlook the benign complaints like headache and floaters. They can be life-threatening. And also with early detection of the melanoma, vision can be salvaged. And also, every patient has its own management of the melanoma, which depends upon the visual potential of the eye, patient expectation, age, and general health of the patient. Thank you very much.
Great presentation, doctor. Thank you very much. Over to judges. Can I have a comment from Dr. Deep Shekhar Das?
Very nice presentation, doctor. I just wanted to ask what kind of plaque was used? Was it a notched plaque or it was a circular plaque?
Sir, it was a circular plaque.
Okay, usually the size, like you're mentioning, it's 20 millimeters. It's supposed to be the larger one, possibly the notched plaque which we use. Anyways, very nice presentation. Yeah.
Sir, size was 11.52 mm at the presentation. So it was below the criteria for the brachytherapy. So we went for the brachytherapy.
Okay, very good.
Okay, very good. Thank you, sir.
Thank you, Deep Shekhar sir. Now over we have the sponsor corner where we'll just put a small video about our sponsor, Neomedics. Over to Dr. Niranjan.
Thank you, Pranesh sir. And amidst the adrenaline rush of the wonderful case presentations that we have, I'm delighted to be here and thank our sponsors, Neomedics and their team, for coming forward to support this wonderful initiative of Noinadi 3.0 going international. And with us, we have Mr. Bipin Malhotra. So thank you, Mr. Bipin, for joining us. And now I'll be playing the video that features their various products. And it will be a video without audio. So don't think that the hearing or any technical glitch is going on. So just to give you a heads up, right? So just a second. I hope my screen is visible.
Yes, your screen is visible. You can play, Niranjan.
Yes. Mr. Bipin, if you would like to share anything, please go ahead while the video is on. So they do have a wide range of products catering to the different needs of an ophthalmologist. And this is the video, which is a compilation of all of them put together. So that's about their video with the products that are already existing and the ones that are coming soon. So once again, we would like to thank Neomedics team for sponsoring our Noinadi session, and over to Pranay sir to take it forward from here.
Thank you, Niranjan. Great lineup of drugs and others from Neomedics. Really enticing to see. I will go to the next participant, Dr. Nyanambika M. She'll be presenting on organ reward syndrome. Doctor, can you?
Manjula ma'am, there's some problem with the timer. I can't fix the timing. It automatically goes.
No, I'm having the control, Karthik. That's
You're having the control. Yeah, fine.
Yeah. Fine. So Nyanambika, you can start your presentation, please, Doctor.
Good evening, sir. Is my slide visible?
Yeah. Yes. No. I'm seeing your face is visible. The slides aren't visible.
Once again. Is my slide visible, sir?
No. Yes.
Yes.
Yes, it is visible, Doctor. Perfect.
Good evening, everyone. I'm Dr. Nyanambika. Can I start my presentation, sir?
Yes, you can start your presentation, Doctor, please.
Yes, sir. I'm a junior resident in IP Center, AIIMS Delhi, and I'm presenting an interesting case on when eyes tell the tale, ophthalmic clues to organoid nevus syndrome. And under this broad entity, we'll be focusing on our patient, how we diagnose and approach the patient under Schmidt-Pinning Fewsien MEMS syndrome, which is a rare neurocutaneous entity with constellation of ocular, cutaneous, and neurological manifestation. A 1-year-old child was brought to us with a complaint of masses over the lateral aspect of both eyes since birth, and the right eye upper lid notch static in size. An antenatal history of gestational diabetes mellitus was noted. No family history, as you could see in the picture. And on ocular examination, binocular cardiac visual acuity was noted at least 6/48 at 50 centimeters. Esotropia was noted, likely due to the mass effect. Lateral canthal skin tag was noted. Right eye upper lid coloboma at the medial 1/3 was noted, and bitemporal lipodermoid, there is subconjunctival firm masses were noted with limbal involvement encroaching into the limbus. Right eye more than 8 clock hours and left eye 4 clock hours, but the central visual axis was clear, noted, and the disc and macula were healthy. This prompted us for a comprehensive evaluation. 1-year child by binocular congenital masses, we went for a comprehensive evaluation, and patchy alopecia of the scalp was noted, and epidermal
abdominal levi along the chest, chin, and back was noted. And the clinching point, this followed the lines of Blaschko. This links to some mosaicism, other disorders. We went for an imaging, and skeletal survey revealed dolichocephaly, that is elongated skull, and incidental subarachnoid cysts were noted in front of both temporal lobes, but the patient did not have any seizure or cognitive delay, so the patient is kept under neurological surveillance. And the rarely reported feature, this posterior scleral cord calcification was noted in the right orbit. This could be likely osteoma or choristoma, that is abnormal normal tissue in an abnormal location. We went for examination under anesthesia, and bilateral epibulbar masses, the extent of the masses were noted, and an ultrasound B scan revealed right eye high spike suggestive of calcification, and on red cam imaging disc and macula were healthy, but juxtapapillary round yellowish lesion. All this corroborates with the choristoma picture. We went ahead as our oculoplasty team went ahead with the surgical debulking of bilateral masses. A conservative approach was taken. Lateral skin tag was excised. Care was taken to not injure the recti muscles or the limbal stem cells. Bleeders were cauterized, and it was closed for better functional outcomes. And since the right eye upper lid notch was small, we went ahead with the direct closure of the coloboma under general anesthesia, and of the both eyes, the similar procedure in other eye. And the patient on follow-up, we gave antibiotic, steroid, painkillers, and lubricant. And post-op day 3, we noted another rare complication, that is pyogenic granuloma, a vascular reaction to the likely due to surgical trauma or suture reaction, and it was resolution with topical timolol therapy, 0.5% ointment, and fluoromethanol tobramycin. And we always send for a histopathology or excision biopsy. It confirmed a complex choristoma. We had lacrimal tissue, adipose tissue, and cartilage components were confirmed in our specimens. So this likely, there is a broad entity, we have multiple entities, but it fits into classically in the Schimmelpenning syndrome, because we have ocular, there is coloboma, complex choristomas, and scleral cord calcification, nevi in the cutaneous feature, and patchy alopecia, and incidental subarachnoid cyst. All this favors into the fits into the Schimmelpenning syndrome than other disorders. So a take-home message is always go for a multidisciplinary. Don't look beyond the lesion. The eye told us a tale for us, and we should go for look for syndromic association. Go for an early multidisciplinary evaluation to improve the quality of life of the patient, and for malignancy surveillance. Thank you so much.
Thank you, doctor. It was a great presentation. Actually, it went over my head. It's too complex for me. So I will call one of the intelligent guests, Dr. Gautam, to ask questions on this, please. Over to you, Dr. Gautam.
Yeah, it was a very rare case. For the first time, I'm also getting to know this. Can you tell some other ocular conditions that can mimic, like resemble an epibulbar choristoma?
We also have in golden hair syndrome.
Yes.
And in this organoid nervous system is a complex entity in which epidermal nevus syndrome was also not a diagnosis, but the constellation of features fits in Schimmelpenning. So these are some of the other one, Proteus syndrome, and etc.
Okay, thank you.
Thank you. Thank you, Dr. Gautam. Thank you, Dr. Nayanamika. Now over to the next contestant, Dr. Nishant S. on orbital inflammatory syndrome. You can exit, Dr. Nayanamika can exit your slide chat.
In the meanwhile, we have a question from Dr. Shruti. Was genetic testing done? Yes.
You can answer that in the chat box, Doctor.
Yeah.
No. Dr. Nishant, yeah, your
Are my slides visible, sir?
You can no, not yet, Doctor.
Oh, I have shared it, sir. It's asking me to stop sharing or hide.
Yeah. Now it is visible. Yes.
Oh yeah. So greetings, everyone. So I'm going to talk
Yes.
about an enigma that was unsolvable. So I'm Dr. Nishant from SDM Medical College. So a 52-year-old female comes to us with the complaints of diminution of vision in the left eye since 3 days. There was history of a trivial trauma 20 days ago to the same eye, to the same side of the face, but it was not significant. So on examination, the visual acuity was 6.6 in the right eye, but 6.18 with no improvement and with pinhole in the left eye. The pupil was RRR in the right eye, but grade 1 RAPD was present in the left eye. And the color vision showed a red-green defect in the left eye. The contrast was normal, 2% both eyes. And the posterior segment evaluation showed nothing. It was just normal. So this was the extraocular movements of the patient. It seems that it's quite normal. There's no problem with this. But the problem occurs when we take a video and when we actually ask her to look from left to right. So you can see here, there is a small lag which is present in the left eye lateral rectus. So when she moves to the right, it is totally fine. And when she moves to the left, the right medial rectus moves first. And after say a second, the left lateral rectus follows it. So there's a lag. Finally, it attains the position, but and she has no diplopia per se. So she attains the end gaze, but there is a lag in the movement of the left lateral rectus. So we got an imaging done. It says, firstly, there was the inflammation of the lateral rectus of the left eye. You can see here. Only the belly was inflamed. The tendon was all fine, and they said that that was pressing on the optic nerve of the left eye. So hence we could explain the color defect and the RAPD. And they also said there's a mild inflammation of the lacrimal gland of the left eye. And then we did our investigations, which everything was normal, and all the autoimmune profile was negative. So systemically, she was all fine. Before the patient, we started her on oral steroids. She was symptomatically better, and after 2 months, her symptoms recurred again. But this time, the color vision had come back to normalcy, and we discovered a new entity that she was on Ayurvedic medication for backache since 6 months. But that was again not significant. Here we can see here it's in primary gaze, totally normal. Right gaze again normal. Left gaze, when it comes to again primary, there's a small this thing here, and when she looks to the left, this is almost 75% there, but this is just starting to move laterally, and this is already attained the end gaze, but this is again almost say 50% there, and after say a second, it has attained the full movement. So we got a repeat MRI. They said that the inflammation was little reduced, but the lacrimal gland remained same. So we admitted the patient, gave her IVMP for 3 days. Vision became 6.6, color vision had no defect, and the lag which was present initially was absent now. The working diagnosis was left eye non-specific orbital inflammatory disease. And what more could have been done at that point was we could have done a biopsy, we could have done a full body CT, and then we could have asked for IgG for serum levels. So after 1 year, the patient was asymptomatic for 1 year, and then she again comes with a proper inflammatory picture of the left eye with redness, proptosis, watering, and pain and everything. So what next? We got serum IgG4 done. It was negative. So what's unique about this case that it is one of the very few cases, actually, according to our literature search, it's one of the first documented cases in the world of NSOIDs to have a presenting complaint as diminution of vision and nothing else. So you can see all these are published cases of lateral rectus myositis or inflammation. All of them have say double vision, swelling, ocular pain, movement restriction, and everything, ptosis. So inflammatory signs. So yeah, take home message: inflammatory signs need not be the first symptoms to occur. We have to think beyond the horizon. 1/4 of the cases are refractory, and time of starting of steroids depends on the person, has to be tailored per case and for the person. So what are questions for you? What is the duration of steroids in NSOID? Because it's not a given thing. And do intralesional steroids help in decreasing the recurrence? Though a few articles say so, it's still a controversial topic. Thank you.
Yeah, nice presentation, Dr. Nishant. Over to the judges, Dr. Gunjan. Can you please give your comment on
Yes.
this?
So I would like to ask, like, if there was a third time recurrence, were any steroid sparing agents started for the patient? Are you planning to start anything like that for long term?
For the third recurrence, the steroid-sparing agents were started. Azathioprine was started, I think, if I'm not wrong, madam. The
Okay.
rheumatologist took a call. But now we are counseling the patient for muscle biopsy, and I think in due course that will happen. And once that
Yes.
gets done, I think we'll have better things to think of.
Yes. Also, um, interesting case. Thank you. Very nice presentation.
Thank you, madam.
Thank you, ma'am. Over to the next participant, Dr. Niba Gupta. A stitch in time saves 9. Doctor, you can exit your share screen. Dr. Nishant, please. Thank you, Dr. Nishant. Have a great day. Dr. Niba Gupta.
Yes, sir.
Yeah, you can share your slides, doctor.
Yes, sir. Is my slides visible?
Not yet, doctor. Yeah, now it's visible. You can go ahead, doctor. All the best.
Okay. Thank you, sir. Good evening, everybody. Myself, Dr. Nibha Gupta. So my case is stitch in time saves 9. So my case is a 12-year-old male child who visited to us on 10th of October 2023 with injury in the school 2 hours back with a left eye lower lid injury, pain and swelling and redness. Other history is insignificant. On ocular examination, the visual acuity unaided in both the eye was 6/6 and near vision was N6 in both the eyes and IOP was digitally normal. Coming to the ocular examination, the right eye was within normal limits while the left eye shows the lower lid medial and lower lid canalicular tear with upper lid superficial laceration and rest of the ocular examination was within normal limits. The retina was in both the eyes was normal limits. So my clinical diagnosis was in both eyes is emetropia and the left eye is lower lid canalicular tear with upper lid laceration. So all eyelid laceration near to the puncta involves the canaliculus until proven otherwise. Coming to the etiopathogenesis, these are the common etiopathogenesis and the commonest being the broken spectacles, blouse hook injuries and dog bites. Coming to the management, what should we do? We should first stabilize the patient systematically. Repair the rupture globe should be performed prior to the definitive evaluation and management of the eyelid or nasolacrimal trauma. If the globe is intact, the diagnosis of canalicular lacerations may be confirmed by introducing a fine Bowman's probe into the lacrimal punctum and out through the wound. And orbital imaging such as CT orbit can be requested for in case of blunt trauma to rule out the orbital fracture. Our plan of treatment was left eye lower lid canalicular tear repair along with mini Monaca stent under general anesthesia. For the timing of repair should be within 48 to 72 hours. Beyond this, fibrosis sets in and it will be difficult to identify the nasal content of the canaliculus. And the driving principle behind this is that wound healing by primary intention is always better than the secondary intention or a late repair. Repair of the canaliculus lessens the risk of patient developing apiphora and also contributes to obtaining good eyelid position postoperatively. What are the challenges one can face during primary management as the nasal or the proximal content of the canalicular laceration may be difficult to identify. So what we can do, we can use a Bowman's lacrimal probe following the natural course or a whitish circular opening of the canaliculus or a lacrimal sign which is known as the calamari ring sign. And what all we can do, we can inject a fluorescent impregnant saline or a ear into the opposite punctum and simultaneously observe the dye appearance or bubbles. And we can use pigtail probe. So this is a surgical video of this patient.
In the local anesthesia, and in our case, the child was taken up for the surgery under general anesthesia. Then we dilate the punctum using the punctum dilator and identify the distal end by inserting the Bowman's probe. Then we take the silicone monocalalicular stent. The end was cut, inserted into the distal end, and pulled out from the other side. We identify the proximal end by calamari ring sign, and then mini monoca is being inserted into the proximal end of the canaliculus. As we can see, it is going easily into it, which is a clue that we are in the right. In the local anesthesia, and in our case, the child was taken.
So post-operatively, we gave antibiotics, painkillers, and steroids. along with antibiotic eye ointment for the local applications. This is a post-operative 1 month picture of a left eye lower lid mini-monoca stent in place. This is pre-op and post-op 6 weeks image. So key learning points is always suspect canalicular injury in any medial canthal laceration. Early identification prevents missed distal cut ends. If missed or poorly repaired, lead to lifelong epiphora and significant morbidity. Timely repair within 48 to 72 hours, guided by precise anatomical knowledge, is the key to restore both lacrimal function and eyelid cosmosis. These are for further readings. Thank you.
Thank you. Great presentation, Dr. Niba. We'll go to Judge Dr. Deep sir for his comments.
Very good presentation, Dr. Neba, and very well managed case actually. I just wanted to know when do you actually remove this mini monoca? And have you heard of bicas? Have you do you use bicanalicular stents?
Sir, I haven't seen any using anyone, but I've heard of. I'm not sure, sir.
Okay, fine. So when you remove this monocular stents,
So once we feel the healing has been occurred, we can remove after a long time. It's not like we can remove, we have to remove it immediately or after 1 or 2 weeks. We can remove it once the healing has set in.
Okay, fine.
Thank you, Doctor. Thank you, Deep sir. Thank you, Niba. All the very best. Next, we go to Dr. Renuka J, fixing the retracted case. Can you share your presentation, Doctor?
Is my presentation visible?
Yeah, Doctor. You can share.
Sir.
Please go ahead. Yes, you can start.
Hello.
You can start, Doctor.
Good evening, everyone. The title of my presentation is Fixing the Retracted Gaze. No financial interest or fixed to disclose. DRS is a congenital cranial dyssynervation disorder, the basic etiology being an aplastic or an hypoplastic abductor nucleus. And there is also an aberrant supply of the LR subnucleus by the MR subnucleus. It is characterized by duction deficits with the globe retraction and shoots on attempted adduction. Though Huber has classified it into 3 types, there is always a blend of presentations. DRS usually presents as esotropia. However, there may also present as exotropia because of an hypoplastic abductor nucleus or a variable extent of misinnervation by the third nerve to the LR, or if there is a fibrotic contracture of the LR. In all these cases, DRS might present as exotropia. This is a case of a 20-year-old female whose primary complaints were difference in size of both eye and outward deviation of left eye. Presenting illness was that the patient was apparently ill at birth, then the parents noticed a difference in size of both the eyes, which was inside as an onset associated with outward deviation in left eye, and which was constant associated with face turn towards left side, and there was no preceding history of trauma, fever, or seizures, and there was no history of spectacle use or patching therapy. The rest personal and developmental history was appropriate for age. General examination was within normal, and on ocular examination, there was a left-sided face turn, and on Hirschberg corneal reflex test, there was a left eye exotropia of 10 degree, both for near and distance. The best corrected visual acuity in both eye was 6/6, and on extraocular movement assessment, there was a abduction limitation noticed in left eye with significant shoots and retraction noticed on attempted adduction. The rest anterior segment examination with the normal in both eyes. Coming to the sensory examination on Worth Fodor test and Bogogini, there was left eye suppression and stereopsis was absent. The prism bar was used to make a measurement of the deviation, and a measurement of 20 prism diopter Bayesian was made. So we have a 20-year-old female with the chief complaints of difference in size of both eye with outward deviation and left side face turn with the left eye suppression noted, and on extraocular movement assessment abduction limitation and noted. So we made a diagnosis of left 1 type 1 DRS with exotropia, and MRI imaging was done to know the status of the abducer nucleus, and it was found to be normal. The left eye lateral rectus recession Y splitting was performed in this patient, and on POD1, the HCRT was ortho, with the best corrected visual acuity being 6/6, and abduction limitation was still present. This is the POD14 image of the patient, where you can see the height in primary position, it is ortho, and the shoots and retraction have been reduced as compared to the pre-op, and the abduction limitation was still persistent. The amount of horizontal deviation corrected is variable in case of DRS. This depends upon the amount of normal fibers which has been supplying your LR from the MR subnucleus. Supramaximal recession in these cases addresses the retraction as well as the slippage, and making a Y splitting will address slippage. But in case of exotropia, recession could also correct the primary deviation depending upon the number of fibers reaching the LR muscle. Take-home message will be DRS presenting with exotropia is rare. Supramaximal recession along with wide splitting of LR muscle reduces the shoot retraction and deviation. Duction deficits are the least to respond in case of a DRS. This highlights the need for individualization of your procedure depending upon the preoperative deviation and targeted surgical planning, by which you could achieve a better functional and cosmetic outcome. Thank you.
Thank you, doctor. Now over to judges, Dr. Gautam.
It was a very nice presentation. Can you elaborate on the mechanism of globe retraction in DRS?
Sir, there is also either it could be hypoplastic abducens nucleus or in case of hypoplastic abducens nucleus, there is a chance of misinnervation by the MR subnucleus to the LR muscle. So there will be a co-contraction. When you attempt on adduction, a number of normal fibers reaching the MR as well as some misinnervated fibers reaching the LR will cause the co-contraction. This results in slippage of the muscle, and this also leads to the shoots in DRS.
Yeah, basic thing is co-contraction of medial and lateral rectus. Thank you.
Thank you, Gautam sir. Now over to the next participant, Dr. Ayushi Bansal.
Yeah, okay, sir.
And I think
Sir, I'm not able to share.
Okay.
Yeah, okay. So are my slides visible?
Yeah. Go ahead,
Okay.
please.
Good evening, everyone. Today I'll be presenting on the topic medial canthus mass, a clinical masquerade. We have no conflicts of interest and consent was taken from the parents to use patient's photograph for medical purpose. So a 14-year-old female presented in our OPD with complaint of swelling near the medial canthus of the right eye since 1 year, which was non-progressive and insidious in onset, associated with watering from right eye, which was on and off, and there was no history of pain, photophobia, headache, diminution of vision, fever, or any discharge or any ocular trauma. Past ocular history was nothing significant, and there was nothing significant to be noted in personal history. On ocular examination to be noted, syringing was patent in both the eyes, and swelling was noted over the lacrimal sac area of right eye, and Rho plus was negative. Otherwise, all anterior segment features were normal. On inspection, as we can see in the image, swelling was noted inferior medially to medial canthus of right eye, which was slight bluish in appearance, approximately measuring 1 by 1 centimeter in size and round in shape. On palpation, swelling was cystic and non-tender, soft in consistency, no changes in surrounding skin, free from underlying structures and skin, and non-reducible in nature. All the basic investigations were nothing significant to be seen, and on CT scan we showed well-defined cystic mass without any intralesional density. And B scan shows an echoic cystic swelling suggestive of simple cyst, hence rules out cysticercosis. So these comes out to be my differential diagnosis: acute acryocystitis, mucocele, dermoid cyst, lacrimal sac tumor, and acryocystocele. Above all the after all the clinical investigations and imaging, my provisional diagnosis comes out to be acryocystocele. So we manage the patient after giving a curvilinear incision over the site as shown in this video. And then the mass was excised and measurements were noted over the table, and patency was checked during the surgery to ensure there is no damage over the canaliculi by a syringing. An incision site was secured with 6-vicryl suture, and samples were sent for histopathology. Histopathology report showed cyst which is lined by keratinizing squamous epithelium suggesting of epidermoid cyst. So my final diagnosis comes out to be epidermoid cyst. This is the follow picture of the patient after 5 days of surgery. Sutures have been removed and surgical site is healthy. There are no fresh complaints. So this is the algorithm, basic algorithm on how to approach a medial canthus swelling. So take-home message from my case is that not all medial canthus swellings are ecramal. Patent syringing could prompt re-evaluation. Clinical examination plus imaging is crucial. Early recognition avoids unnecessary surgery. And hemolycria, extension above the medial canthus tendon, adherence to the surrounding structures. All these features differs malignant versus benign. Thank you.
Yeah, nice presentation, doctor. Now,
Thank you.
no issues. Aishi Bansal, now we can, is Dr. Aishi there?
Yes, sir, I'm there. Am I audible?
Yeah, Aishi,
Yes,
you can go ahead, Dr. Aishi, can go ahead.
Yeah, so very nice presentation, Ayushi. I'm sorry
Thank
for the background noise as I'm traveling.
No
So yeah, very nice and crisp presentation. I just wanted to ask you, do you have the facility of doing a dicryocystography at your place? Because that would have, like, told you beforehand whether it's a dicryocystocele or any other mass that is adjacent to your lacrimal sac.
No, ma'am. Unfortunately, we don't have this yet.
Okay, so it's a very easy to perform. You can always talk to your radiologist for that.
Okay, ma'am.
Because they always have the contrast available. All you have to do is go and inject. So
Okay,
it's a
ma'am.
very accessible and feasible modality, and it tells you the relation of your sac with the mass.
Okay, ma'am. Okay.
Very well presented.
Thank you, ma'am. Thank you.
Thank you, Dr. Aishi, for your great comments. For the next presentation, we have Dr. Rahul VR.
Good evening, sir.
Evening, Rahul. Your slides are visible. You can go ahead, Doctor.
Okay.
All the best. Thank you.
Thank you, sir. Good evening, everyone. I'm here to present on Good evening,
Voice is
everyone.
not.
I'm here to present. Sir?
Go
Is
ahead,
it
go
okay?
ahead, Doctor. Go ahead.
I'm here to present on when the cure leaves a mark. So fixed drug eruption is a rare but significant adverse reaction which is characterized by erythematous villosius as a circular patch reappears on the same anatomical location when administration of the offending drug. So simple pathogenesis is it's a delayed hypersensitivity reaction due to mammary T cells which is located on the epidermis. So incidence range from 2.5 to 22%. So there are many various presentation of FD based on the morphology, location, and based on the histopathology and special types. So it is challenging for a clinician to suspect and treat accordingly. So here we go. It is a 74-year-old male came for cataract surgery, left eye hypermature cataract. We have he's a known case of systemic hypertension since one year on regular medication. No past allergic history to drugs and foods. We have started on moxifloxacin drops and predfort eye drops, ciprofloxacin tablet. After 10 hours, patient developed erythematous itchy lesions over right forearm, left index finger, and we have stopped ciprofloxacin. And after 12 hours of initial lesion, patient developed again a new lesion over right upper eyelid and right thigh region. Dermatology opinion obtained and stopped topical moxifloxacin. Punch biopsy sent from right forearm and started on oral steroids. After 3 days, patient showed signs of bleeding. So these are the pictures of fixed drug eruption in the various sites. And histopathology image showed intraepidermal blisters containing acantholytic cells, lymphocytes, and macrophages. Epidermis shows spongiosis, dyskeratosis with basal vacuolar degeneration, and perivascular lymphocytic infiltration with pigment incontinence, which is suggestive of FDE. So this is a histopathology image, intraepidermal blisters with acantholysis, and this is dyskeratosis with basal vacuolar degeneration, as you can see here. And this is pigment dispersion from epidermis to the dermis. And this is perivascular lymphocytic infiltration. And this is the healing phase of the patient after 3 days. So we have reported this case to pharmacopoeia, Indian pharmacopoeia. And discussion part, FD accounts for 20% of all adverse reaction. These are the list of drugs. And common sites include lips, genital, palms, soles, and mucosa. Drugs specific sites include carbocysteine can involve face, NSAIDs, tetracycline, trimethoprim can involve genitals, and metamizole can involve trunk and extremities. So pathogenesis, it is a delayed type of hypersensitivity reaction. This is depicted easily in this image. The local mammary T cells gets activated when the patient consumes the offending drug, and it releases interferon gamma and granzyme B, which causes this erythema pigmentation and necrosis of the keratocytes, causing FDE. So histopathology is the confirmatory investigation. Other investigation we can do is oral and skin patch test. In acute phase, there'll be dyskeratosis, basal cell hydropic changes, and perivascular lymphocytic infiltration. On recovery phase, the patient will have hyperpigmentation with melanin-laden macrophages. So fixed drug eruption to topical medication is very rare. So there is one case reported for olapatidine topical solution. So this case concludes the importance of clinician to have a differential diagnosis of fixed drug eruption in their differential diagnosis and treat accordingly. Thank you, sir.
Thank you. Thank you very much, doctor. Just 1 second. Now I would like to go to Dr. Gunjan Saloja for her
Right.
comments on this case, please.
Yeah, so very interesting case. I think before starting any drug, not just moxiflox, many of the patients they do have allergies with the fluoroquinolones.
Yes,
So before starting any drug, I think we should ask the patient about the history of drug
Yes, ma'am.
allergy.
Yes,
So
ma'am.
sulfa drugs are another notorious class of drugs. Many patients are allergic to that also.
Yes,
Very
ma'am.
nice presentation and a crisp presentation. Thank you.
Thank you, ma'am.
Thank you, Gunjan madam, for your comments. Now on to the next presentation, Dr. Mriganka Sarkar.
Yes, sir.
Yeah, your slides are visible. Yeah, perfect, doctor. You can share. Go ahead, continue, please.
Okay, sir. Hello everyone, I am Dr. Mriganko Sarkar. Today I am talking about the swollen truth, decoding the hidden face of diabetes affecting optic nerve head. I have no financial interest. So first is introduction. Diabetic papillopathy is the rare cause of optic disc edema seen in 1.4% of type 1 or type 2 diabetic patient. It occurs regardless of metabolic control and severity of diabetic retinopathy, hyperemic optic disc swelling and telangiectatic vessel seen on or around the disc. Now coming to my case, a 52 years old male patient, businessman by profession, presented to IOPD with complaining of sudden onset painless progressive worsening of defective vision in the both eyes over the past 2 months. He had no history of periorbital pain or redness, no history of headache, double vision, nausea, vomiting or pulsatile tinnitus, no history of flashes of light or floaters, and no history of ocular trauma at the time of presentation or previously also. He was a known case of type 2 diabetes mellitus and hypertension on medication. On examination, both general and systemic examination were within normal limit. On external examination, I had not found any abnormalities. Now coming to the ocular examination, uncorrected visual acuity in the right eye was 636 part and it was improved to 636 with pinhole. And in the left eye, uncorrected visual acuity was 660 and it was not improved with pinhole. Nuclear sclerosis grade 2 was noted in the both eyes. Now coming to the fundus examination, it was done by slit lamp biomicroscope with 90 diopter lens and indirect ophthalmoscope with 20 diopter lens. In the right eye, disc margin was blurred inferiorly, sarcinate pattern of hard exudate noted at macula, and inferiorly dot and blot hemorrhages were seen. And in the left eye, disc margin was blurred circumferentially, hard exudate noted along the superior and the inferior arcade, dot and blot hemorrhages and cotton wool spots were noted. Envy was present. Now coming to the investigation, laboratory investigation revealed the level of HbA1c was 8.9, spectral domain OCT macula was done in the right eye center involving DME and intraretinal fluid with PED, and in the left eye, intraretinal fluid and hard exudates were noted. HVF 24-2 Shita standard revealed enlargement of blind spot in the both eyes. MRI brain and the orbit were within normal limit. So it was a case of moderate N period in the right eye and period in the left eye with bilateral diabetic papillopathy in a case of type 2 diabetes mellitus with immature senile cataract in the both eyes. Now coming to the treatment, intravitreal anti-VEGF, ranibizumab 0.5 milligram given in the both eyes to treat diabetic retinopathy and DME. Patient reviewed after 1 month and vision improved to 6 618 in the right eye and 624 in the left eye. But left eye disc margin was blurred and resolving CSME was present. Then high dose intravenous methylprednisolone 250 mg every 6 hours in 100 ml NS for 3 days, followed by oral prednisolone 1 mg per kg per day for another 11 days were given to treat diabetic papillopathy. After 14 days, BCVA further improved to 612 in the right eye and 618 in the left eye, and disc margins were clear. PRP of the left eye was planned. Now, coming to the discussion, diabetic papillopathy was first described in 1971. Since it is a diagnosis of exclusion, it is critical to rule out other possible causes. Corticosteroid stabilizes the blood-retinal barrier and decreases inflammation, which extends the successful outcome in this patient. So far, no clear recommendation have been established. However, diabetic papillopathy is generally known to have a good visual prognosis. Now, coming to the conclusion, as diabetes is highly prevalent, it is necessary for eye care provider to be familiar with some of the less common ocular complications of diabetes mellitus, including diabetic papillopathy. Patient needs to be followed up at regular interval with close monitoring. These are my references. Thank you.
Great presentation, Dr. Mriganka. I would like to, like Dr. Kamashweta, to ask a few questions about this case.
Good presentation, doctor. So I just have a query, like, was the diabetic papillopathy, like actually it doesn't require any steroids. So it is a self-limiting disease. Like, what was the rationale behind giving IVMP in this patient? And it was like an ONTT protocol which was given.
Sir, ma'am, actually, patient actually vision was poor and the disc margin was blurred. After treating diabetic retinopathy, patient has still blurred vision and resolving CSME was present. So we give injection methylprednisolone, ma'am.
Oh, actually, here I think in this case the drop in vision was because of CSME, and anti-VEGF was given, and it needs to be waited. Like within 2 weeks, it won't have its complete effect. So usually diabetic papillopathy and in diabetic papillopathy there will not be any vision that will be affected. So I think it could have been waited and treated only with anti-VEGF.
Ma'am, we have waited
Because it is
after we have waited 1 month, ma'am. After that, we gave injection methylprednisolone.
Okay, but that is what is my experience. Usually, papillopathy doesn't require any treatment. It will self-resolve. Thank you.
Thank you, ma'am.
Thank you, doctor. Now over to next, we have Dr. Rahul VR on Sjogren's with hypercoagulable state.
Good evening, sir. Am I audible, sir?
Yes, you're audible, Dr. Ekran. Please go ahead. All the best.
Thank you, sir. Good evening, everyone. I'm here to present on primary Sjogren's with hypercoagulable state. So, 1 minute. So introduction, papilledema is a non-inflammatory passive swelling of the disc, usually due to raised intracranial pressure. It is due to idiopathic or secondary to space-occupying lesion, cerebral venous thrombosis, infection, AV fistulas, and obstruction to ventricular and aqueous outflow obstruction. So Sjogren's is the second most common multisystemic autoimmune disorder. Usual presentation will be keratoconjunctivitis, Zika, and xerostomia. On the other side, due to protein C, protein S deficiency, it can cause thromboembolism. So, 35-year-old male came with complaints of headache, which was bilateral throbbing in nature, present over the back of the head since 1 month, associated with nausea and vomiting since 1 week. She had a history of fever with right parotid gland enlargement 1 week back, no relevant past history, and no comorphs. So, on general examination, pallor was present, rest were normal. Anterior segment examination, shimmers and T-bud was reduced. Cornea showed superficial punctate keratitis over the inferior quadrant, rest were normal. Fundus showed both disc margins were blurred with obscuration of the vessels over the disc margin, and peripapillary retinal nerve reflex was absent. Rest of the fundus was normal. It was established papilledema, and HFA done, and it showed enlargement of the blind spot. So MRI brain and contrast was advised. It showed internal jugular vein and right sigmoid sinus thrombosis, and neurologist opinion obtained advised CT venogram, which showed right IJV and right sigmoid sinus thrombosis. And blood parameters, patient had anemia and ESR was elevated, protein C, protein S was reduced, anti-nuclear antibody was positive with anti-SA was strongly positive and anti-Rho 52 KD was strongly positive. Lip biopsy was normal. So diagnosis, both are established papilledema secondary to venous thromboembolism with Sjogren syndrome, treated accordingly. So patient came for review after 1 month, symptomatically better, vision and color vision was normal, shimmers improved. So MRI brain, which we had done before initiation of treatment, which showed sigmoid sinus filling defect, and after treatment of after 1 month had resolution of right sigmoid sinus. So discussion, protein C, protein S inactivates factor 5A and 8A, which helps to regulate blood clot formation with on deficiency, which cause hypercoagulable state. Sjogren's can indirectly contribute to prothrombotic state by chronic inflammation, endothelial damage, and autoimmune mediation, which enhances the clotting mechanism. And anemia is another factor which could exacerbate the venous hypoxia due to reduced oxygen delivery, which worsens the congestion, causing CVST. So thus, this case illustrates the importance of ophthalmology, ophthalmologist's role in early detection of systemic illness just by simple evaluation and examination to prevent further complication. Thank you.
Thank you, Dr. Rahul. Great presentation. Now over to Dr. Kamashweta on our questions, please.
Yeah, thank you. Good presentation.
Thank you, ma'am.
So, like, apart from this, like, even in a young male, when they come, we will have to do MR venogram to rule out
Yes,
this
ma'am.
cerebral venous sinus thrombosis.
Yes, ma'am.
So, what other conditions, like, would you like to do the cerebral MR venogram?
In order to rule out
In papilledema, is it like only in this? Like, apart from if the patient was not having Sjogren's, so
yes, ma'am.
what other condition would you like to do this MR venogram?
Cerebral venous thrombosis, we will do, ma'am.
Yeah.
As this case we have
Apart,
done them.
yeah, apart from that, even in IIH, we need to look for the stenosis of transverse sinus.
Okay, ma'am.
So even if this patient was not having any Sjogren's hypercoagulable state, also in any papilledema, it is advisable to do MRI brain with MRV.
Venogram.
MRI brain orbit with MRV nogram, yes, to look for the
Okay, ma'am.
sinus. Okay, thank you.
Thank you, ma'am.
Great presentation. Thank you, Koma madam, for your nice comments. So for the next presentation, we have Dr. K. Janani on unforeseen diagnosis beyond vision case. Yeah, slides are visible, doctor. Go to your title slide and then you can start.
Good evening, everyone. Today I'm going to present on the topic Beyond Vision, Uncovering Unforeseen Diagnosis Through Visual Field Testing. About 85% of the cerebrovascular accidents are ischemic in etiology due to cerebral infarction. They can present as transient ischemic attack where infarction is detected on imaging, but there are no symptoms. Patients are at highest risk of subsequent stroke within the first week after a transient ischemic attack, but the risk of subsequent stroke at 1 year follow-up varies from 4.4 to 21%. So many studies tell that 80% of the patient post-stroke will have visual impairment, although the stroke patients with visual disturbances like hemianopia, but not hemianopia is not the only presenting symptom in stroke. That is rarely reported. This case demonstrates the crucial nature of the isolated presentation of visual field loss due to occipital lobe infarct. So hence, an appropriate use of ancillary diagnostic tests like visual field analysis is important in diagnosing the devastating disease. A 58-year-old male presented to the department with the complaints of diminution of right-sided field of vision loss for the past 5 days, and he noticed it while driving. There was no history of any trauma, fever, or headache, profuse vomiting, double vision, and limb weakness. And he was a known hypertensive and type 2 diabetes patient, and he was on irregular medications. And there was no significant family or personal history. The general examination were normal. Systemic CNS examination also was found to be within normal limits. Coming to the ocular examination, the visual acuity was 6.6 in both the eye, and intraocular pressure was 18 also in both the eye, and other anterior segment investigations were within the normal limits. Coming to the fundus examination, both the macula showed a few yellow waxy well circumscribed lesion in the macula with few red dots suggestive of microaneurysms and dot blot hemorrhages. And in the background retina showed multiple dot blot hemorrhages and multiple fluffy yellow white lesions along the arcade suggestive of cottonwool spots. This is the fundus picture showing the multiple dot blot hemorrhages, cottonwool spots. And on Humphrey visual field 30-2, the patient showed right homonymous hemianopia. And this is the MRI brain showing area of diffusion restriction with T2 hyper intensity lesions and few foci of blooming on gray. So investigations, RBS was elevated 280 and triglycerides, total cholesterol, HDL and LDL was elevated. Other investigations were within normal limits. So visual field assessment is important in the evaluation of lesions involving the visual pathway and should be performed at baseline and periodically in the follow-up. Occipital lobe infarcts frequently have deficits in homonymous visual field that are quite congruent. And neuroimaging is mandatory in the diagnosis. Like MRI is less prone to artifacts and exhibits better contrast discrimination in posterior fossa. And intravenous thrombolysis administered within 4.5 hours is the first line management of stroke, and isolated visual symptoms can be the early indicator of stroke also. So there is only a limited time window during which the stroke therapy is effective. So prompt recognition of these atypical symptoms is essential for timely intervention. These are the references and thank you.
Thank you, doctor, for your presentation. I would like to Dr. Koma to give her comments on this case.
Yeah. Nice presentation. Dr. Janani, I have one question. So
Thank you,
what
ma'am.
kind of visual rehabilitation can you give in these patients? If the visual fields are persisting, then what kind of rehabilitation can we give for this patient?
On improving the infarction, ma'am, maybe their visual acuity will improve.
Hello?
On timely
visual-
intervention with thrombolysis.
Usually in this kind of infarct cases, the visual fields will improve very minimally. In this case, visual acuity was normal as you showed 6, and 6. So
Yes, ma'am.
what are the other, when the visual field defect persists, what is the rehabilitation that we can give for this patient?
Maybe compensatory training can be done, ma'am, for that patients and optical aids for those patients.
So what optical aids? Okay, so we have to teach them, as you said, compensatory head scanning and paired prisms can be given with the base towards the side of the visual field defect.
Okay,
So
ma'am.
this
Okay.
patient had right homonymous hemianopia, right? So
Yes, ma'am.
we have to give base out in the right eye and base in the left eye.
Okay, ma'am.
So that is a visual rehabilitation that we can give for this patient.
Okay, ma'am. Thank you.
Gunjan, madam, can you give your comments on this?
Yes, I think Dr. Koma has already asked questions regarding the case and nice presentation. We can move on to the next case, I guess.
Thank you, ma'am.
Thank you, madam. Thank you. For next presentation, we have Dr. Jyoti Sri. Yeah, your
Yes.
camera is on visible, doctor. You can start your presentation.
Yes, sir.
Yeah.
So my case, good afternoon, everyone.
Screen share, doctor.
I have shared my screen, sir. Is it
No.
visible, sir?
No, it's not visible.
It's not.
Would you need some time, doctor?
No, sir. I'm sharing right now, sir.
Yeah.
Is
You
it
have shared,
visible now,
doctor.
sir?
Yeah, it's visible. Yeah. Thank you, doctor. Go ahead.
Yes, sir. Thank you. So, good afternoon, everyone. So, I'm going to present a case of recurrent eyelid basal cell carcinoma, presented after 2 years. So, a case report. So, I'd like to go upon this. Is it moving to you, sir?
No, Dr. Jyoti.
No, Dr. Jyoti.
Moving. It's not moving.
Mm.
Just click the mouse inside and then move your arrow.
Yes, sir.
Try now. Yeah, perfect.
Is it now,
Be
sir?
lenient on the timing. Don't worry. Manjula ma'am, can we restart the timer?
Okay, doctor.
Yeah. Start from the first, doctor. Yeah.
Yes, sir. So recurrent eyelid basal cell carcinoma after 2 years, a case report. So I want to go about this presentation in 3 sections. So first, how the patient had presented to us and how we had diagnosed, and the surgical procedure and its excellent result, and about the recurrence also, which the patient came to us recently. So in 2023, this patient, 42-year-old female, tailor by occupation, presented with a 4-year history of progressive swelling in the lower eyelid in serious onset, and the swelling breaks and heals on and off by its own. And there was complaints of itching, and there was a history of similar lesion in the past 8 years back, which fell off by indigenous method of removal through the tying the lesion by hair, and following which the newer lesion started appearing at the same site. There was history of sun exposure also. The patient had no comorbidities, no significant past history. On examination, there was this ulcer of size 10 cross 8 millimeters present lateral one-third of the lower lid margin, involving the lateral canthus. There was a loss of eyelashes also in the lateral half of lower eyelid. The margins were irregular, the surrounding skin was pigmented, and dry, rough, keratinized surface was there at the center of the lesion with raised beaded edges. So on palpation, there was no warmth, no tenderness, so inspective findings were confirmed. The ulcer was fixed to the underlying tarsal plate, hence immobile. There was yellow color discharge also seen. The lid margin was distorted and notched. There was no lymphadenopathy, no tenderness. The visual acuity was full 6 by 6. The extraocular movements were full and free, and the anterior and posterior segments were normal, emphasizing localized involvement. So we went on to do the systemic investigation. Everything was found to be normal except for the anemia part. And the CT orbit showed a well-defined hypodense mass lesion, which also indicated towards a tumor. And incision biopsy was done, which also told that there was evidence of carcinoma. And melan A was negative, S100 was negative, which are negative markers for BCC. So again, it's a BCC. And coming to the surgical management, we did a wide local excision with frozen section and lower lid reconstruction with Hughes procedure. The radiotherapy was advised to the patient, but the patient had refused. And 6 weeks after the Hughes procedure, we did a release and division of the lid. So this is some of the intro pictures, but I like to explain it with my own diagrams. So this tumor was resected by a pentagon-shaped wedge, giving 4 millimeters margin medially, laterally, and inferiorly, and we extend the incision to supratemporally also. And for filling this defect, we did the Hughes procedure. We everted the eyelid. We took the tarsoconjunctival flap. We pulled the posterior lamella down, and we filled only the middle half of the defect was be able to fill. For the lateral half, what we did was we mobilized the periosteum from the lateral orbital margin, and we fixed it with the tarsoconjunctival flap and the skin surrounding it. So after 6 weeks, we did the release and division of the flap, followed by a continuous suture for forming the lower lid margin. And this is the result. So from this to this, the cosmesis was restored, and the function of the lid was also restored. The patient was very happy. The excision biopsy findings was that it's a basal cell carcinoma, and especially this patient had a nodular basal cell carcinoma characterized by a nest of basaloid cells with peripheral palisading and occasional spindle cells. This subtype may show central ulceration and telangiectasia, and also there is this one of the DD is also pigmented BCC, which is a rare variant which can resemble melanoma, where UV exposure is to be ruled out. So post-op care was given, and close monitoring is very essential for such patients because radiotherapy was not given. There is risk of recurrence, and development of ectropion is always a possibility in such patients because of the surgery per se. And fast forward to 2025, the patient came to the OPD with the complaints of the swelling. She had 2 cross 2 millimeter round blackish swelling just adjacent to the previously operated site at the middle of the right lower lid, which was covered by a layer of skin. So for this, we did a excision biopsy, and we are actually currently waiting for the reports. Sir.
Yeah.
So yes, sir. This is my
Thank
comment.
you. Thank you, Doctor. Great presentation, Dr. Jyotishi. I'll ask.
She had a 30-second glitch in the start, so she ended right on time. Just wanted to tell that yeah, she ended.
You want to give something on the finishing note, Doctor, for 10 seconds?
No, sir. That's.
Yeah, great presentation. Great
It
slides.
requires timely diagnosis and procedures like Hughes procedure. We cannot just rely on procedures like Moss micrographic surgery because such things are not, the microscope are not available in intraoperatively in few places. So such wide local excision with frozen section is itself enough, and along with that, our own innovation, our own input for the surgery is also important. Like we mobilize the periosteum from the lateral orbital margin in addition to the Hughes procedure. So I think this is it.
Great, doctor. Over to doctor. We have a panel from Dr. Aishi, oculoplastic surgeon. Can you ask a question to the candidate, madam?
Sure. Very well presented, Dr. Jyotishri.
Thank
I
you,
just
sir.
had a few questions. How did you cover the anterior lamella? Like, very well made diagram. First of all, I really appreciate you making the diagram on your own. From what did you cover the anterior lamella? So that was posterior lamella, the periosteal flap with hoops.
We just inverted it back, ma'am.
Okay, so you could have done a skin advancement, I believe, or maybe you can take a posterior auricular skin graft also. It depends on the age of the patient because the skin is lax, or if it is not, then you can take a skin graft also. So you have to look at both the things, the anterior lamella as well as the posterior lamella.
Yes, ma'am. Yes, ma'am.
Yeah. And can you tell me what is the significance of Milan A coming negative? Like in what tumor would you expect it to be positive?
For melanoma, ma'am.
Right.
Yes.
Yeah. So that's it from my side. Over to you, Dr. Pranesh.
Thank you. Thank you, Dr. Aishi. It was a great question. And now next we go to Dr. Nandita Trivedi. You can exit your screen sharing slide. Doctor.
Yes, sir. Yes, sir. Thank you, sir.
Yeah, thank you, ma. Dr. Nandita Trivedi.
Yes, sir. So is my screen visible?
Yeah, your screen is visible, doctor.
Yes.
Presenting on metastatic lung cancer. You can start.
So just a minute. So is my screen visible?
Yes, yes. Slideshow, you're ready to go. I can start your slideshow.
So actually the tab is coming in between my screen. I'll just
No, it's perfectly fine. Yeah, go ahead. All the
Okay,
best.
okay. Yes. Good evening, everyone. I'm Dr. Nandita Trivedi, and I'll be presenting on unmasking metastatic lung cancer through orbital apex syndrome. There are no financial disclosures, so I'm unable to move to the next slide.
Okay,
Okay.
Dr. Nandita, just
Yes,
click
sir.
on inside the slide and now try to move the right arrow.
So I'll just
Go to the slide
try
presentation.
it again.
Yeah.
Yes, sir. Inside and
Now try moving. Works.
oh yes, sir, it's working now.
Manjula
Yeah.
ma'am, can we restart the timer? You can go to your first slide, Dr. Nandita.
Yes, sir.
Yeah.
Unmasking metastatic lung cancer through orbital apex syndrome. There are no financial disclosure. Orbital apex syndrome is a rare ocular condition with life-threatening complications. It can either be due to mass effect on the structures traversing through orbital apex or due to direct infiltration of these structures. I'm presenting a case of 60-year-old female who presented with sudden onset painless diminution of vision and inward deviation of left eye since past 1 week. They were associated complaint of fever, headache, vomiting, tingling sensation over the left forehead, pain in right lower limb radiating to right hip. On general physical examination, multiple nodules on scalp and dorsum were noted, and enlarged submandibular lymph nodes were noted. Systemic evaluation. On CNS evaluation, there was decreased proprioception along the ophthalmic branch of trigeminal nerve and hyperreflexia in bilateral knee and ankle joint. Ocular examination. The best corrected visual acuity in the left eye was hand movement close to face, PR inaccurate. RAPD was noted in the left eye. Hirschberg test revealed 15-degree esotropia and limitation of left eye extraocular movement in levoversion, levo elevation, and levo depression were noted. No other abnormalities were detected on anterior segment or posterior segment evaluation. Investigations were carried out. On blood investigations, increased ESR was noted, decreased TSH, T3, T4, FSH, LH, and cortisol levels, and increased serum H was noted. CSF analysis was found to be normal. Contrast enhanced MRI of brain and orbit revealed asymmetric hyperintense enhancing lesion of the cavernous sinus. PET scan of whole body revealed active soft tissue density lesion in the left lung with metastatic lesions in brain, scalp, cervical, and mediastinal lymph node. And HRCT chest revealed soft tissue hyperdensity in the left lower lobe. Efficacy of nodules from scalp, dorsum, and submandibular lymph nodes revealed metastatic mucin secreting adenocarcinoma. Ultrasound guided biopsy was done from the right thigh lesion and it revealed atypical cells in sheaths and nests with few signet ring cells, and tumor markers CA125 and CA were found to be positive. We had initially kept differential diagnosis of systemic infection with CNS involvement, sarcoidosis, thyroid eye disease, and idiopathic inflammatory disorders amongst the differentials. However, after elaborate investigations and examination, we made a provisional diagnosis of primary lung mucin secreting adenocarcinoma with systemic metastasis to CNS, scalp, and orbit. The patient was referred to oncology department and radiotherapy was planned for the patient. However, the patient declined to oncological intervention and the patient was kept on palliative care approach. The patient ultimately succumbed to her illness secondary to septic shock and multi-organ failure within 1 month of presentation. Discussion. Ophthalmologists should have high index of suspicion for underlying tumors in these cases, for which prompt identification of the cause is a must. Detailed and meticulous medical workup is essential with multidisciplinary team approach management. Literature review suggests that breast and prostate cancer are the most common site of primary tumors that tend to metastasize to the orbit. Take home message. Orbital apex syndrome due to orbital metastasis can be the primary presentation in case of lung cancer. It is associated with grave etiologies that warrant a meticulous workup, and a multidisciplinary team approach is needed in the management of these cases. Thank you so much.
Great presentation, Doctor. Now over to Judge Dr. Komashweta. Panel, Dr. Komashweta, for comments, please.
A nice presentation, Dr. Nandita. Well managed. So I have a query for you. Like, how do you differentiate whether it is orbital apex, like clinically, or it is a superior orbital fissure involved?
Yes, ma'am. Ma'am, in superior orbital fissure syndrome, there won't be involvement of optic nerve, so there won't be vision won't be affected in superior orbital fissure syndrome. However, in cavernous sinus syndrome, optic nerve involvement is there. I'm sorry, in orbital apex syndrome and in cavernous sinus syndrome, ma'am, there will be involvement of the 5-2, that is the maxillary branch of the trigeminal nerve, and also there can be involvement of sympathetic plexus, which can cause Horner syndrome.
Very good. And I just want to give one comment. After all the investigations, you have put the differential diagnosis. You should put that slide before telling about the investigations.
Yes, ma'am. Yes, ma'am.
And provisional diagnosis also before the investigations. The final diagnosis you can put after the investigation.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
Very good presentation.
Thank you so much.
Thank you.
Yeah. Over to the next presenter, Dr. Angel Smriti Kullu. Dr. Angel?
I think Dr. Angel is not. If you're, I will just unmute you. I think AS is Dr. Angel Smith here. Can you unmute yourself?
Dr. Angel, are you there?
No, I can see someone named AS. I think.
No, I think this is shifted. It's okay. Just leave it. I think that's been shifted.
Pranesh, we'll move to the next person.
Yeah, we'll go to the next person, Dr. Shweta Shri.
I'll try calling her.
No. It's shifted. Sorry, no, not shifted.
Okay,
Shifted.
okay.
Yeah.
Fine, then fine.
Yeah, Dr. Shweta Shri.
Yes, sir. Am I audible, sir?
Yes.
Good evening, everyone. I'll be
The slide should be presented, Doctor.
Are my slides visible, sir?
No. Slides are visible, Doctor.
Yes, sir.
Yeah, go ahead, please. You can start, Doctor.
1 minute, sir. Slides I'm not able to see.
If it's not moving, keep the mouse inside the slide, click on the slide and now press your right arrow. After you click inside the slide, now press on the right arrow and check whether the slides are moving. Or, yeah, perfect. Perfect.
So good evening. I'll be presenting interesting causes of cases of eccentric proptosis in children.
One second, doctor. Timer is not started yet. One
Yeah,
second.
please start, madam. Please start.
Yes.
Doctor, you can start, Shweta.
Case 1, a 10-month-old male child presented with complaints of swelling in the right eye along with forward protrusion for past 3 days, which was gradually progressive and painful in nature. There was history of self-fall and sustained injury over the right side of forehead before 3 days. The general examination, systemic examination, and vitals were within normal limits. Ocular examination, head posture was normal and there was no facial asymmetry. Visual acuity, there was fixing and following with both eyes open. Intraocular pressure was within normal limits, and the right eye on primary gaze was hypotropic and the left eye was orthophoric. Anterior segment examination showed fullness in the right superior orbital sulcus associated with diffuse erythematous lid edema. Rest of the findings were within normal limits. On inspection, there was proptosis of the right eye with downward and outward dystopia of the globe. And there was on palpation, it was a 2 cross 2 centimeter firm swelling and the surface was smooth, not adherent over the underlying skin. There was no enlargement of regional lymph nodes. There was restriction of extraocular movements on elevation in the right eye. The fundus examination showed presence of splinter hemorrhages in the background in the right eye, and the rest of the findings were within normal limits. A differential diagnosis of orbital hematoma, abscess, emphysema, lymphangioma, or tumor was made, and CT orbit was done to rule out presence of hematoma or space-occupying lesion. CT orbit plane showed findings suggestive of right subperiosteal retrobulbar hematoma. The child was managed conservatively with topical and oral antibiotics and topical NSAIDs. The child was asked to continue the same medications, and as the swelling subsided on subsequent visits, swelling, proptosis, and splinter hemorrhages got completely resolved along with extraocular movement fullness. This is the follow-up picture of the child. Case 2, a 12-year-old female child came with complaints of swelling and forward protrusion of left eye for 1 week, which was sudden in onset and painless in nature. She was a known case of acute myeloid leukemia on treatment with chemotherapy 2 years back. There was a history of scalp swelling 1 month back, for which excision biopsy was done, and findings which are suggestive of Ewing sarcoma or rhabdomyosarcoma. A second scalp swelling was noticed 1 week later, for which she was advised chemotherapy again, and the patient did not follow up. General examination, systemic and vitals were within normal limits. There was presence of a 5 cross 5 centimeter swelling on the forehead, which was hard in consistency. Ocular examination was within normal limits, and IOP was within normal limits. Anterior segment examination showed presence of large 2.5 cross 2 centimeter non-tender mass, which was hard in consistency in the superomedial quadrant, causing inferotemporal dystopia. The rest of the findings were within normal limits. There was a restriction of elevation in the left eye, which was -3 in primary position in dextro and levo elevation. Contrast enhanced MRI orbit in T1 weighted image showed hyperintense soft tissue lesion, T2 weighted showed hypointense lesion, and T2 flare image showed hyperintense soft tissue lesion involving the left extracorneal space. Bone marrow findings, immunohistochemistry, blood investigations, and excision biopsy of scalp swelling was done, and morphological possibilities of synovial sarcoma, Ewing sarcoma, and embryonal rhabdomyosarcoma was made. The first case, based on the time of presentation, visual acuity, and any presence of communicating bleed, the management can be either observation, follow-up, and intravenous steroids, or surgical exploration. Whereas in second case, the management can vary from chemotherapy to surgery and radiotherapy, and can proceed with allogenic hematopoietic stem cell transplantation. The prognosis is bad in this case as it is an early sign of systemic relapse. So why this case? This is to emphasize the wide range of clinical presentation of eccentric proptosis in children, where proper history taking aids in the appropriate modality of investigations to arrive at a definitive diagnosis and prompt treatment. Thank you.
Nice presentation, Doctor. We'll invite Dr. Shruti to ask any comments.
Yeah, very nice presentation. Two different spectrums were discussed. Why was a undisplaced fracture in the first case?
There was history of trauma, ma'am. The patient had had trauma 3 days back in the right forehead, ma'am.
Okay. So was that managed conservatively?
Conservatively managed, ma'am. After 1 month, everything had resolved. The extraocular movements were full, and the repeat CT was done, which I had not documented actually. It was all resolved, ma'am.
Okay. Anyway, very nice presentation, and I think I don't have any
Thank
further
you, ma'am.
comments.
Yeah. If any judges or any panel has some question, they can ask, or we'll move to next speaker.
Yeah, so I just had a question for her. You said the morphological differentials were RMS and Ewing's also. So what marker would you do to rule out rhabdomyosarcoma?
Not sure about that, ma'am.
Okay, so it's desmin and myogenin. So whenever you're suspecting RMS, that will be included in the panel because it's that is also a differential of your round cell tumor. So desmin and myogenin.
Okay, ma'am.
Yeah.
Okay.
Great presentation.
Thank you, ma'am.
Nice. We can move on to the next presenter, Dr. Tulika.
Yes, sir.
Dr. Tulika?
Yes, sir.
Yeah, fine. Very good.
One second, sir.
Yeah.
No
Can you
issues,
pause
doctor.
the timer? Yeah.
Yeah, I'll take care of it. No issues.
ये पूरा PowerPoint है.
शेयर के नहीं हो रहा है. स्टॉप शेयर करके वापस शेयर करोगे तो ऊपर का स्टॉप करो.
Dr. Tulika, your slides are not moving, right?
Yeah, sir.
Just click the mouse inside and then try to move it. Click inside the slide, move it. Press on the right arrow.
Is my screen visible, sir?
Yeah, it's visible. It is very much visible. I want you to go and click inside the screen. Yeah.
Yeah, it's moving.
Perfect. Use your arrow key.
Yeah.
Key. Yeah.
Sir, shall I start?
Yeah, you can start.
Hello everyone, I'm first year DNB resident from Naadi Pai Hospital. I don't have any financial disclosures and appropriate consent has been taken from the patient. I'm presenting a case of 34-year-old female who presented with clinical complaints of watering in left eye since 9 months and swelling, which was painless and gradually progressive. There was no history of trauma. She was diagnosed elsewhere as recurrent mucocele and probably underwent lacrimal intervention 1 year ago elsewhere. Her best corrected visual acuity was 6/6 and 6. On examination, there was inferomedial lesion with bluish tinge and was limited below medial canthal tendon. There was no erythema or any signs of inflammation. On palpation, the lesion was firm, non-tender, and well-defined. The mass was cystic and compressible. Rhoplast was negative, and the lacrimal irrigation was freely patent. The ocular motility was full and free, and rest of the ocular examination was within normal limits. The patient already had computer-tomography dacryocystography films which revealed a well-defined heterogeneous isodense lesion with few areas of hypodensity within the lesion in the left lacrimal fossa, with slight superotemporal globe displacement. Bony remodeling was noted suggestive of long-standing etiology. The optic nerve, extraocular muscles, and the globe architecture were within normal limits. In the axial bone window, we can see the dye in both the NLDs, suggestive of patent lacrimal drainage system with no evidence of tumor in the nasolacrimal duct. The remodeling changes are further highlighted in the sagittal section here. Suspecting an lacrimal drainage system neoplasm, a left dacryocystectomy with excision biopsy was planned. Pre-op counseling with risk of residual epiphora, visible external scar, and possible recurrence was explained to the patient. A tear trough incision was made. Intraoperatively, a bluish thin-walled lesion was exposed. Further dissection led to the rupture with egress of chocolate cyst fluid. The walls of the lesion were brownish and were completely excised. Intraoperative irrigation revealed patent lacrimal drainage system, suggestive of mechanical secondary acquired lacrimal drainage obstruction due to adjacent cavernous venous malformation. Immediate postoperative course was uneventful and the excised tissue was sent for histopathological examination. This is the scanner's view showing the lesion. which on higher magnification revealed extensive areas of hemorrhages with inflammatory infiltrates and focally overlying stratified columnar epithelium. This is the magnified view further highlights the distended vascular channels, which are lined by endothelial cells with pale cytoplasm admixed with extensive areas of hemorrhages and fibrinous exudates. Confirmatory of left eye cavernous venous malformation based on clinico-radiopathological examination. And this is our patient at 1 month follow-up with no residual epiphora, resolved lesion, and patent lacrimal drainage system. Through this case, I learned that not every inferomedial swelling is a lacrimal mucocele. A thorough clinical examination with lower threshold for lacrimal imaging is recommended. A CT-DCG is useful lacrimal imaging modality to assess the relation of the lesion with respect to lacrimal sac and NLD and to localize the extent of the lesion which influences the management plan. Whenever in doubt, biopsy the atypical pathology rather than sinning on the side of doing a DCR, which may lead to spread of the tumor. With this, I would like to thank YOSI for the opportunity, my mentors from NEH, and my seniors for guiding me. Thank you.
Yeah, wonderful presentation. Now we'll invite Dr. Gautam to share your comments, please.
Whether you'll do incisional biopsy or excisional biopsy in this case, and what are the intraoperative steps you will take to avoid bleeding, minimize bleeding?
Sir, first of all, I'll do excisional biopsy.
Okay, very good.
And to minimize, since it is a well capsulated benign tumor, so to minimize bleeding, so as it is well defined, we will cautery and tranexamic acid can be also used.
Yeah, actually, you can dilute, infiltrate with
cortical.
diluted adrenaline, and bipolar cautery should be meticulously done.
Yes,
There is something called hypotensive anesthesia also that can also be tried. Thank you.
If we don't have any more questions from the judges or panel, we can move on to the next participant. Dr. Vaishali.
Yes, sir.
I think Dr. Tulika can stop share, screen share. Yeah. In me.
So is my slides visible?
Yeah, your slides are visible.
Okay. So good evening all. I'm Dr. Vaishali, Junior Resident, Naadi Eye Hospital. I do not have any financial disclosure and appropriate consent has been obtained from the patient. So I'm presenting a case of 5-year-old girl child with complaint of sudden onset forward protrusion of right eye since 2 weeks. However, there was no history of recent trauma, upper respiratory tract infection or pain. These are her old photographs showing right side mild proptosis since childhood. She was diagnosed with orbital lymphangioma elsewhere 5 days ago and undergone treatment with methylprednisolone, was not relieved. In the right eye, best corrected visual acuity was 6/60, and at nasal examination revealed right side painless massive abaxial proptosis of 25 mm with superotemporal globe displacement. It was non-distensible on postural variation. Fullness was noted on the upper lid with conjunctival hypertrophy in the inferior and nasal quadrant. There was no pulsation or bruise. Lack of thalmos of 3 mm was noted with telangiectatic vessel over eyelid, and warm spew further showing the abaxial proptosis. Extraocular movement was limited in all the direction of gazes in the right eye. Rest all ocular examination was within normal limit. So based on these clinical findings, we made differentials: first orbital rhabdomyosarcoma, venolymphatic malformation, and leukocytic infiltration, and advice for magnetic resonance imaging, which shows diffuse intracorneal lesion with a fluid level extending up to the apex of the orbit, abutting the optic nerve. Also, we can see posterior bowing of the posterior globe, so giving classic guitar pick sign, which indicates of compartment syndrome and involvement of ethmoid sinus also. In the further in the coronal and the sagittal section also, we can see the macrocystic fluid lesion. So based on our clinical and radiological finding, right eye diffuse orbital venolymphatic malformation causing orbital compartment syndrome, we made provisional diagnosis, and patient was then went for urgent cyst aspiration with 13 ml of hemorrhagic fluid was aspirated and 6 unit of bleomycin was injected, and with post-op oral corticosteroid and topical steroid, patient was reviewed at 4 weeks, where proptosis reduced drastically and vision restored to 6 by 6. Subsequently, in the second setting, 6 ml of fluid is aspirated and 8 international unit of bleomycin was injected, and we can see further reduction in the proptosis. We then go for repeat MRI, where we can see marked reduction in the proptosis. Angle of globe is restored, but there is residue in the inferomedial and intraconal compartment. Then we plan for third setting, 6 weeks apart, where 4 ml of fluid is aspirated and 6 international unit of bleomycin was injected, and further reduction in proptosis was noted. This was the fourth and the final setting, where we performed surgical debulking through inferior transcutaneous approach, and 4 international unit of bleomycin was injected, and this is the final follow up of this patient, where the proptosis was reduced to 3 millimeter and vision was restored to 6 by 6. So the take home message from this is the orbital VLMs are always challenging to manage. Identification of guitar pick sign on imaging provides cue for urgent intervention for vision salvage. Intralesional bleomycin sclerotherapy is currently the first line of management with an excellent response, especially in the macrocystic and mixed variant. Meticulous injection technique is warranted to avoid the visual complication, and endpoint based upon the response and outcome as well as patient expectations. Thank you.
Yeah, a nice presentation, well on time. Now we invite Dr. Deep to share your comments, please.
Very nice presentation, Doctor. And I would like to appreciate the image qualities. Actually, very good images that you have shown. I just wanted to ask, what are the conditions where you actually see fluid levels on MRI?
So mainly we have the whenever we have the whenever we have the lymphatic malformation along with the venolymphatic component, we see this fluid level.
The idea is basically there has to be two different fluids. Okay, so even if it's a dermoid with a or an abscess also, you can actually appreciate them. So there has to be two different densities of fluid. Beautiful images, very nicely managed.
Yes.
Perfect. Okay, nice.
Do you have any more comments, Dr. Gunjan or? Yeah, fine. We can move on to the next presenter, Dr. Shifa. I think Dr. Vaishali, you can stop your slide shares.
Yes.
Dr. Shifa, are you there?
Yes, sir.
Yeah, I can hear you. Okay, you have started your screen shares. Fine.
Can I start, sir?
Yeah, you can start.
Good evening, everybody. I'm Dr. Shifa Sheikh from Naadi Hospital, DNB resident. I do not have any financial disclosure, and appropriate consent is taken from the patient. So I'm presenting an interesting case of 47-year-old lady who was homemaker by occupation, came with complaints of recurrent medial canthal swelling since 4 months and associated with discharge and pain since 4 months. 1 second. Am I screen visible?
Your screen is visible. I have just passed your time.
One second. Sorry.
Yeah, fine.
It was a known case of diabetes mellitus and was on intermittent oral antibiotic therapy. She had undergone left eye ptosis repair surgery in her childhood. Her family history and personal history was not so significant. On general examination and system examination, all were within normal limits. Ocular examination. Her best corrected visual acuity was 6, 6, and 6 in both eyes and normal head posture. On agnasal evaluation, as we can see, there was elevated erythematous lesion predominantly in the inferior-medial aspect, slight extension above the medial canthal tendon, edema and erythema extending to the upper eyelid lesion, with raised tear meniscus height and moderate residual unilateral ptosis. On palpation, we can see the swelling was ill-defined, fluctuate, and firm in consistency. There was tenderness present and rhoplast was negative. On ptosis evaluation, we can see in left eye there was lid lag in down gaze with 12 LPS action and with good bell phenomena. Her ocular motility was full and free. Rest of the ocular examination was unremarkable. So we came on a conclusion of provision diagnosis, left eye recurrent acute dactylocystitis with lacrimal abscess and preseptal cellulitis. We started the treatment by aspiration of the abscess using 24 gauge needle, about 1 ml of purulent fluid, and simultaneously she was started on oral antibiotic therapy. We planned her for early endoscopic DCR but got postponed due to her high sugar levels. After 5 days of review, the edema and erythema, as we can see, has reduced and the size also reduced. She underwent this uneventful endoscopic DCR with intubation and MMC was applied under the GA. After 1 month post-op, the epiphora resolved and the fluorescent dye disappearance test, there was no delay in it. But now here's a twist. Now comes the swelling over the medial canthal area, which is still persistent. So we did a nasal endoscopy. As we can see in the video, the fluorescent endoscopic dye granuloma with surrounding flame tissue. We excise the granuloma and inject the intraregional triamcinolone acetonide. Patient was restarted on intranasal and topical steroids, and a short course of oral corticosteroid therapy was given. After 6 weeks, the swelling reduced and granuloma resolved, and we continued the intranasal steroids for 2 weeks. After 2 months of post-op, we can see the medial canthal swelling completely resolved. On the nasal endoscopy, the fluorescent endoscopic dye test was spontaneous and positive, as we can see in the video. With good ICO dynamicity, no cicatricial closure, no ICO threads, granuloma completely resolved. According to the FICI osteum grading, it was 5 and 5, excellent. So, I learned 3 things from this case. First, this multi-pronged approach for recurrent acute dactylocystitis, including abscess aspiration, early endoscopic DCR, post-op nasal endoscopy evaluation. Second is frequent post-op endoscopy is evaluations necessary to prevent the failure as seen in this case, and early management of osteum granuloma depending upon the type and size. Thank you, YOSI, and my mentor and co-authors for giving this opportunity to present.
Nice presentation, well on time, Dr. Shifa. I would like to invite Dr. Gautam to share his comments.
So what are the two important differential diagnoses here? One is granuloma and the other is abscess, right? How do you clinically differentiate them?
So we had done a computer tomography also.
No, clinically, how do you differentiate?
Clinically, we'll see, so this swelling is there, fluctuant swelling will be there, erythema, redness will be there, lot of discharge will be there, and lacrimal abscess.
Basically, fluctuant and tender. In case of granuloma, what will be the features?
Granuloma, there will be a swelling, sir, and there will be like no tenderness or redness.
Swelling will be firm, actually.
Firm in consistency, yes. Hot and firm in consistency.
Okay. If you have any comments from Dr. Deep or Dr. Gunjan, if not, we'll move to next participant.
We can move to the next slide.
Yeah. Next participant, Dr. Akansha.
Hello, sir.
Yeah, your screen is visible.
Sir.
Slides, yeah. Yeah, your slides are visible. You can start.
So hello everyone. So today I'm going to be presenting this case of an attempt to rescue a patient from proptosis that went slightly haywire, and how these series of events ensue we shall see in the upcoming slides. So our patient was a 27-year-old young male patient who presented to the OPD with the chief complaint of swelling, which was first noticed by the patient in the right eye, and this swelling was progressively increasing on size. On inquiry, there was no history of trauma or surgery. There was no history that was suggestive of any kind of an infective or inflammatory pathology. There was no history of weight loss, loss of appetite. The patient had no relevant systemic history, including the history of thyroid disorder, no history of headache, tinnitus, and no history of any visual symptoms, including color desaturation, diplopia. So visual acuity for the patient in both right and left eye, unaided for distance as well as near, was 6.6 and 6. External examination was unremarkable. Apart from an axial proptosis, which was noted in the right eye on inspection, resistance was felt to retropulsion. There was no bruit, no pulsation noted. On Hertel's exophthalmometry, a difference of 4 mm was present between the two eyes. Slit lamp examination was also unremarkable. Posterior segment examination unremarkable, apart from a lattice which was present in the inferior periphery in the right eye. So the patient already had a CT report that he had done elsewhere, which was suggestive of an intracorneal lesion, but the films were not available with the patient, so a contrast-enhanced MRI was advised. And here we can see in these even contrast-enhanced images, there is a homogeneously enhancing mass which is present all around the optic nerve, pushing the optic nerve slightly medially. So the radiologists give the possible differentials, including cavernous hemangioma and the schwannoma. And with these differentials, the patient was advised to undergo lateral orbitotomy, mass excision, and HP under GA. So this is an OT note from the same surgery where the dissection was attempted to be done in toto, but it was not possible as the tumor was very much adherent to the optic nerve. So piecemeal dissection was done and the medial part of the tumor could not be dissected. However, intraoperatively, there was fixed dilated pupil that was noted, which indicated a touch in the ciliary ganglion. So here the tissue was sent for biopsy and the case was closed. On the first post-op day, the vision of the patient dropped to 612, but he had no specific complaints. The proptosis resolved to some extent, and the patient was started on oral steroids. Day 3, the patient's vision dropped further to 660, and there was an LR palsy present. So a fundus examination was done. So this is a fundus picture from the same day, where we can see that there is profuse subialim bleed, and also there is profuse vitreous hemorrhage, which was emanating from the disc. This is an OCT image from the same day, which shows subialim and subhyaloid bleed again, along with vitreous hemorrhage. So right eye was provisionally diagnosed to have subialim bleed and vitreous hemorrhage due to breakthrough bleed from the optic nerve head. This bleed was suspected to be subarachnoid bleed in origin. It was emanating from the blood vessels in the meninges of the optic nerve head. So to confirm the diagnosis, repeat MRI was advised for the patient, but due to financial constraints, he could not undergo the same, and the patient was kept on observation for the vitreous hemorrhage. Meanwhile, the histopathological report for the patient arrived, and it was suggestive of IOID, for which he was started on long duration steroids. 1 month post-op, the best corrected visual acuity of the patient worsened to CF2, and there was now dispersed vitreous hemorrhage with retina attached on ultrasound. And this is an ultrasound image with the subialim bleed and the vitreous hemorrhage emanating from the optic nerve head. Again, in the hopes of spontaneous resolution, the patient was kept on follow-up. 1 month post-op, the visual acuity and the posterior segment status was not improving, so he was advised vitrectomy, which he underwent. And 1 month post the VR surgery, the patient obtained good visual acuity of 6 parts and 24 in the right eye. The retina was attached, all the breaks were well seen. There was no recurrent bleed. This was the last recorded visit for the patient. However, he's still on follow-up. So the take-home messages I would say would be that for such orbitotomy cases, it is very important to have a good imaging so we can have a good pre-op plan. We have to counsel the patient well for all the possible complications that can arise, and also in case we can see that the tumor is adherent to the optic nerve, instead of going for heroic measures, we should always try to conserve the vision. Thank you.
Okay, nice presentation, Dr. Akansha. Now we will invite Dr. Gunjan to have any comments, please.
Yes, a nice presentation and a very well managed case. What did the excision biopsy of your patient showed?
Ma'am, it showed IOID.
Okay. And then patient later developed vitreous hemorrhage also along
Yes.
with that.
Yes, ma'am. After
Okay.
the excision biopsy.
So how do you explain the presence of vitreous hemorrhage in this patient?
Ma'am, in our case, we were suspecting that due to trauma during the surgery or due to the shearing forces, there was a bleed that developed under the meninges of the optic nerve, which progressed anteriorly and moved on to the posterior segment. Other differentials could be that post GA, the patient might have strained or coughed. That could have led to valsalva retinopathy. And other than that, there could be an inflammatory CRVO due to the edema that was present post-surgery.
Okay, thank you. Nice presentation.
Thank you, ma'am.
Well managed case.
Thank you.
Yeah. Okay. If you don't have any comments from other judges or panel, we can move on to the next participant. And Dr. Mugatala, are you there? Dr. Mugatala? Can I, Dr. Mugatala? Okay, I don't think, can anyone see her? Doctor?
I'm calling her. You can go to the next person.
Yeah, okay, we'll go to the next presenter, Dr. Sahila. Dr. Sahila, are you there?
Yes, sir. Yes, sir. Yes, sir. I'm here.
Yeah, you can share your screen.
Is my slides are visible?
No, not yet. You have to go, the share button is at the bottom of the Zoom. Yeah, started. Yeah, you can go to slideshow.
Okay. Good afternoon, all. I'll be presenting a case of reversible.
Yours is not in a slideshow mode. Just go click on the slideshow. Yeah, go up, slideshow, or at the bottom anything. Slideshow start from the beginning. Yeah, you can start.
Good afternoon, all. Myself Sahila. I'll be presenting on reversible field defect, a rare case of posterior circulation stroke. A 40-year-old female, with no known comorbidities, hailing from Villipuram, presented to our casualty with a complaints of acute onset occipital headache, blurring of vision, and unable to see left side located object for 3 days. Following by which she developed 2 episodes of seizure, which was 30 minutes apart, associated with a loss of consciousness, which brought her to hospital with no other significant history. On general examination, the vitals were found. The blood pressure was 170-110 millimeter of mercury, and the pulse rate was 101 beats per minute, and the random blood sugar was 290. And systemic examination was within normal limit. Coming to the ocular examination, extraocular movements were full and free, and the right eye visual acuity, uncorrected visual acuity was 612 parts, and left eye uncorrected visual acuity was 69 parts. Color vision and contrast sensitivity within normal limit. Rest of the anterior segment was within normal limit. On dilated fundus examination, there was no evidence of disc edema, no evidence of hypertensive or diabetic retinopathy changes. On confrontation test, it showed left-sided homonymous hemianopia, and we proceeded with the C-field 30-2, which concluded the same finding. And my differential diagnoses are posterior circulation stroke, which can be thrombotic or hemorrhagic, posterior reversible encephalopathy syndrome, and intracranial space occupying lesion. We proceeded with neuroimaging. The non-contrast CT was done, which showed a wedge-shaped hypointense area in the right occipital region, which can be because of cytotoxic or vasogenic edema. Since NCCT is very less sensitive for diagnosing both, to differentiate both vasogenic and cytotoxic edema, we proceeded with the contrast enhanced MRI. On T2 flare sequence, it showed focal wedge-shaped hyperintense. On T1 sequence, it showed hypointense area. On diffusion weighted image, it showed diffusion restriction, which is concluding more towards cytotoxic edema, which can happen in fact. Renal function was done, which was within normal limit. Fasting lipid profile was dearranged. Then carotid Doppler was done to rule out any atherosclerotic obstruction, which showed echogenic plaque in the right common carotid artery, which obstructing the 50% of the lumen. Renal artery Doppler was done in because of the patient has young age and also hypertension to rule out any renal causes like renal artery stenosis, which was found to be normal. And echo was with a normal limit. So my final diagnosis left homonymous hemianopia, secondary to posterior circulation stroke with diabetes mellitus and hypertension. So after obtaining the CTVS and the neurology opinion, patient was started on antiplatelets, oral hypoglycemic agents, and antihypertensive agents. And BP was monitored closely, and the patient was discharged once the BP was normal. And 6 months later, patient was reviewed in OPD. The visual acuity was improved to 6.6, and C-field 30-2 was repeated, which showed almost total recovery. And key learning points are the early recognition and the timely intervention can prevent permanent deficit. The visual field loss may be reversible if managed promptly and serving as a crucial window to detect serious and potentially life-threatening systemic conditions. And it emphasizes the importance of multidisciplinary approach. Thank you.
Thank you, Doctor. Can we call upon Dr. Komasweta to give your valuable comments, please?
Thank you. Nice presentation, doctor. So I have a question for you. How do you differentiate whether it is an infarct or posterior reversible stroke?
Yes, ma'am. The clinical presentation was an atypical presentation. In case of posterior reversible encephalopathy syndrome, patient will mostly present with seizure, visual field defect, and headache. In case of PCA, in fact, patient will have mostly cerebellar features. Since the patient was having mixed findings, we did an NCCT which was not conclusive, and in MRI it was showing the diffusion restriction, which is mostly seen in case of infarct or cytotoxic edema, which is not seen in case of vasogenic edema. The posterior encephalopathy reversible syndrome can cause vasogenic edema.
Okay, very good. So that's what in DWI, in posterior reversible encephalopathy, we see hypo or iso, whereas in infarct, we see it as hyperintense lesion. And in this case, actually, the patient was lucky that even if it was an infarct, there was reversible of visual fields for this patient.
Yes, ma'am.
Thank you.
Okay. If you have any other comments from other judges, Dr. Deep or Dr. Gunjan or Dr. Ayushi, anything, or else we can move on to the next presenter.
We can move on to the next presenter.
Yeah, next presenter. Can we move to Dr. Neil? Are you ready?
Am I audible, sir?
Yeah, you're audible. You can share your presentation.
Okay, sir. Is the presentation visible, sir?
Yeah, you can start your slideshow. Yeah.
On it. May I start, sir?
Yeah, you can start.
Okay, good evening to everyone. I would be presenting a case of pediatric thyroid eye disease, Graves in a 10-year-old child, which is as rare as 1 in 10 lakh children per year under the age of 11, as quoted by the American Academy of Ophthalmology in 2023. So a couple of days from today, a child came to us with mild protrusion of eyes, palpitations, and heat intolerance since past 1 month, along with hair loss, fatigue, and weight loss since past 6 months. The child had a staring look. The pulse was increased. There was an increase in respiratory rate, and there was a diffuse swelling present on the neck of the child. An interesting finding of vitiligo patches was present on the trunk of the child. The importance of this we'll talk towards the end of the presentation. So the visual acuity was preserved to be 6.6. The lids were retracted, and inferior scleral show was present on the conjunctiva, as we can see in the picture. Axial proptosis was present, periorbital fullness was there, and the overall clinical activity score was found to be 0. The Hertel's exophthalmometer value were 21 and 22, which is comparatively higher to a child of the similar age group as compared to previous studies. The fundus, visual fields, color vision, and extraocular movements were within normal limits. With this, my differential diagnosis is Graves, idiopathic orbital inflammatory disease, orbital myositis, or leukemia. Further on, we did investigations, and thyroid appeared enlarged and heteroechoic with increased vascularity on ultrasound. Along with this, the differential IOP was also slightly higher in the upper gaze. On the contrary, the MRI orbit and the A scan, B scan values were within normal limits. This is an important slide where we can see how the TSH receptor antibodies are humongously high as compared to normal, along with an increase in T3 and T4 values with a decrease in TSH values. So my final diagnosis is bilateral axial proptosis, probably because of thyroid eye disease in an inactive stage. Joffre sign, Koch's sign, Darlempe sign, and Stellwags were present to support my diagnosis. Before I come to the management, the father of the child was counseled of the importance of follow-up to repeat hurdles, vision, color vision, and look for any progression. The child was started on tablet carbimazole 3 times a day and CMC eye drops. Now, for the vitiligo patches, the child was referred to the pediatric endocrinologist, and to our surprise, a couple of days itself before, the child turned out to be positive for pernicious anemia. So now, why are these vitiligo patches important? Two retrospective studies across 2 countries in the world show that 24 to 25% of children with vitiligo, when retrospectively studied, turned out to be positive for thyroid antibodies. Now, why is this case important for us? There are certain subtle differences in the management of pediatric and adult graves. Now, maximum of the pediatric graves are mild in nature, as shown in a study in 2023 of India, and the first line of treatment is anti-thyroid drugs. In adults, if it is moderate or severe, we usually combine it with surgeries. Coming to an RCT that was done in USA, radioactive iodine had higher risk of worsening the orbitopathy, which tells us an important point that if radioactive iodine is considered, steroid prophylaxis should be used along with it, as it reduces the risk of radiation-induced exacerbation of orbitopathy. Second take-home message is 25% of the pediatric vitiligo patients have thyroid abnormalities, and thus screening of pediatric vitiligo should be considered as a routine. Follow-up is of utmost importance so as to prevent any rapid progression, especially associated with other autoimmune disorders. There are 2 important points before I end for today. We all know the benefit of selenium that has been proved for mild cases in adult graves. But in children, this evidence is lacking, and 80% of the children with graves are mild in nature, and hence this opens us to a new avenue of research. Teprotumumab, which is an insulin-like growth factor IGF-1 blocker, is approved by US FDA for moderate to severe active graves, but no such studies are present in children, and thus this can also be a new avenue of research. These are my references. Thank you.
Nice presentation, well on time. We would call upon Dr. Ayushi to give your comments, please.
Hi, Dr. Neil. Very nicely and lucid presentation. I just have a couple of questions for you. Since how long did the patient notice the proptosis?
Ma'am, around 2 months, ma'am.
Okay. So where would you place this patient in the Rundle's curve? The active phase or the inactive phase?
Inactive phase, ma'am.
Okay, so it's 2 months, so it will be in the active phase. But the other thing would be the activity, which you do by what are the scores for your activity?
Ma'am, clinical activity score, ma'am.
Yeah, so what would be the clinical activity score in this case?
Ma'am, in this case, it would be 0, ma'am.
Correct. So clinically, it is inactive. But since the onset is 2 months, the patient is still in the active phase of the Rundle's curve.
Yes.
Right. And just wanted to comment on the newer avenues. Teprotumumab is not available in India. So we are still awaiting those research avenues in adult thyroid eye disease. And the second thing was the benefit of selenium. So the study that talks about selenium, they found that those people had selenium deficiency. So that is also a controversial matter, that do we really have selenium deficiency and whether selenium would really benefit us. So these are the 2 things that I wanted to point out. Last question, how would you differentiate thyroid eye disease from idiopathic orbital inflammatory disease on imaging?
Ma'am, depending upon the swelling of the muscle, like the Coca-Cola sign will be present, ma'am. That could be one of the differences.
Sorry, what will you see in the swelling?
Ma'am, the muscle belly with tendon sparing.
Correct. So that's the characteristic of thyroid eye disease. Yeah. And orbital myositis again would be a spectrum that will include your TED and IOID. So yeah, okay. That's it. Thank you.
Thank you so much.
Okay. Do we have any other comments from the judges or panel?
Dr. Karthik, I just want to ask one question. Dr. Neil, why was the IOP more in up gaze?
Ma'am, actually, the MRI of the orbit was normal, but we were assuming that the inferior rectus has started being getting involved in the initial stages, ma'am. That could be one of the reasons of the increase in IOP in the upgaze. One of the first muscles to get in.
Yeah, why is it the first muscle to get involved in thyroid eye disease?
Ma'am, the connectivity around the inferior rectus muscle that is just dense, because of the surrounding adhesion, ma'am, the surrounding structures, because of that, it gets
More
initially.
concentration of glycosaminoglycan receptors.
Yes, ma'am.
And what is that sign called?
Coca-Cola sign. I'm not
No,
sure.
no. The differential IOP in upcase, it's called Barley's sign.
Yes, ma'am. Rails test.
Okay. Thank you. Nice presentation.
Thank you.
Thank you. Now we'll call upon the next presenter, Dr. Anita Kumari. I don't think I can see Dr. Anita Kumari in the thing. Dr. Anita Kumari, are you present? Okay. Yeah. In the meanwhile, we'll call upon Dr. Aprajita Shukla.
Yes, sir. Am I audible?
Yeah, you're audible. You can start your presentation. But your screen, yeah, fine.
Can you see my screen?
Yeah, I can see your screen. You can start your presentation. Timer, can anyone start a timer?
1 second, Karthik. I'm working on it.
Yeah, I just lost the timer. Can you please start?
Yeah.
Okay, so
yeah, you can.
Good evening, everyone. This is Dr. Aprajita Shukla, and my topic for today is neurofibromatosis type 1 with plexiform neurofibroma and veiling a neural mutation. I have no financial conflict of interest in relation to the work presented. So my case is of a 16-year-old female presented with a 5-year-old history of gradually progressive painless swelling of the right upper lid, along with localized skin swellings, lumps in occipital and flank region, with episodes of transient loss of consciousness. It was painless, gradually progressive swelling of the right upper lid. It was initially small, slowly increased in size and associated with drooping of the lid. There was no associated pain, redness, or diplopia, and other systemic features included history of cafe au lait spots and axillary fracking and occasional transient loss of consciousness. There was no history of any ocular trauma or ocular surgery and no history of any chronic systemic illness. The ocular history of no surgery, diplopia or squint, no systemic illness, and the family history was positive in the aunt and the maternal grandfather also, giving it as an autosomal dominant inheritance. On general examination, the patient was well nourished and there was no dysmorphism. The skin had multiple cafe au lait spots as seen in the picture, distributed over the dorsal region. Axillary and palmar fracking was also present. There was localized lumps in the flank region, in the left flank region, and also in the occipital region. CNS, CVS, respiratory were within the normal limits. On ocular examination, the visual acuity best corrected was 6.9 in the right eye with soft, ill-defined plexiform neurofibroma. And anterior segment, we saw Lisch nodules on the slit lamp. There were no restrictions in the extraocular movements. Fundus, we did not show any choroidal lesions, gliomas, etc. And the IOP was normal in both eyes. Assessing the examination of the eye, we saw there was the palpebral fissure height was 8 mm, that is less compared to the fellow eye, and the type of ptosis was mechanical ptosis with neurogenic involvement due to the neurofibroma. So the patient went on for the surgical excision of the plexiform neurofibroma. This is the pre-op picture and this is the post-op picture for the direct comparison of the preoperative conditions with the significant function and cosmosis. The MRI brain orbit was done and it had showed no intracranial or optic pathway glioma. Ultrasound swellings, ill-defined hypoechoic lesion on histopath, spindle cell lesion with interlacing bundles and wavy nuclei was found, that is neurofibroma. On genetic evaluation, there was whole genome sequencing was done, and we found a novel NF1 variant on exon 9, and this variant was classified as likely pathogenic, and it was absent in all population databases, making it as a significant discovery. So, as understanding the NF1, it is a diphtheric neurofibromin, leads to increased RAS NAPIC pathway, and a novel NF1 mutation, first of its kind, was unveiled through this ophthalmic case. This is the first reported case and expand the mutation spectrum. And this case highlights how novel genetic findings contribute to deeper understanding of the NF1 diversity. So, through clinical examination and symptom analysis, genetic testing to identify the systemic mutation, and combine the clinicians for precise and genetic counseling, integrated approach, accurate diagnosis facilitates the effective genetic counseling for the patient and the family. As an ophthalmology, we often detect first one to detect can be first one to detect the NF1 mutation, highlighting its crucial role in early diagnosis. So one patient, one mutation, yet a discovery that can reshape how we see, diagnose, and care for generation. Thank you.
Okay, nice presentation. Now we'll call upon Dr. Ayushi to share your comments, please.
Excellent presentation, Aparajita. Congratulations. And the way you have, explained every sign in the general and ocular examination is commendable. I would request all residents to, do that in the OPDs. Yeah, I just have a couple of questions. Maybe I missed that. Did you image the patient?
Sorry, ma'am. Did you?
Did you do any orbital imaging?
Yes, ma'am. I've done MRI orbit and brain, but we did not found any optic glioma, any lesions associated with the neurofibromatosis.
Okay, in terms of enophthalmos or exophthalmos, did anything was there in your patient?
No, ma'am, it was not there. Only the plexiform neurofibroma causing mechanical ptosis was present,
Okay,
along with the nodules, of course.
Right. And was there any sphenoid wing dysplasia?
No, ma'am. No, ma'am.
I'm asking because it looked a little enophthalmic to me, and the reason would be a sphenoid wing dysplasia that will be very well highlighted in a CT or a 3D reconstructed image.
Yes, ma'am, we did the imaging, but we did not found anything else apart from the things I highlighted in the.
Okay. Can you also tell me another differential for an S-shaped eyelid? One is plexiform neurofibroma. Any other differential of an S-shaped upper eyelid?
Ma'am.
Any lacrimal gland inflammation or lesion would have an S-shaped eyelid because the lacrimal gland is
Lacrimal
superior.
gland is the same.
Yeah. Great. Very nicely presented.
Thank you so much, ma'am.
Yeah.
Okay. Do you have any comments from Dr. Deep or Dr. Gunjan or Dr. Komal Sweta? Okay.
I think she has covered most of the important parts. I think she could have added one more thing for the newer modalities which are being currently studied, experimented on, but like MEK innovators which are currently being experimented
So
for.
Selametinib.
Okay.
Yes.
Hello.
Yes, sir. Am I audible?
Yeah.
Yes, so Selametinib is a MEK1/2 inhibitors.
Yeah, there are different. I think recently an FDA approval has also been reached for a different one, meremetinib or something. I'm not exactly sure of the name.
Yes.
For adult and younger age as well, for non-resectable neurofibromas. But I think nowadays we have to work on orbital neurofibromas. Possibly some kind of dosing metric has to be changed. Anyways, okay, nice presentation. Otherwise, I think
Dr. Deepshekhar, I had a question for myself.
Sure.
That are these available in India, like free to use?
No. As of now, it's still majority of them are only available in the Western countries actually. But still, the literature is actually coming up. So possibly in the future, we're going to start it here as well.
Okay. Thank you.
Okay, nice. Do we have Dr. Anita Kumari here? I think Dr. Anita Kumari is missing.
She's not there. She's not there.
Yeah.
I just connected with her. She's not here. She's not joining.
She's not here.
Yeah, fine. So we'll move upon to the last present. We have last presentation, Dr. Nishita. Dr. Nishita, are you here?
Yes, sir. I'm here, sir.
Yeah. So I request everyone to be available, all participants and all judges panel, everyone to be available for the e-certificate distribution after this presentation. Yeah, you can start. Nishita, you can start sharing your screen.
Yes, sir. Screen. Sir, can you see my presentation, sir?
No, I can't, we are not able to see. You have to go to share screen, which is at the center and bottom.
Yes.
And go and share screen. You have to click the share screen icon and go to the presentation. Yes. Now you have started sharing.
Yes.
Yeah,
Can you
your
see it now?
presentation ready. You can start.
Yes, sir. Good evening, all. Yes, sir. So today I'm here to present a case. The patient is 50-year-old male. He came to ophthalmology OPD with complaints of headache, more towards the occipital region and visual disturbances for past 10 days. He's a known diabetic. He came with complaints of blurring of vision, which is gradual in onset and non-progressive in nature. And patient had headache bilaterally and more in the occipital region for past 10 days, which worsens on coughing and sneezing and is not associated with vomiting. The patient had a similar complaint 6 months back, for which the patient used over-the-counter medications and the symptoms were resolved. The patient had no history of diplopia, no previous trauma, history of just the patient is having diabetes and he's on medication and is well controlled. No history of fever, myalgias, or no other known comorbidities. Personal history and family history otherwise was nil significant. Coming to general examination and systemic examination was within normal limits. Coming to ocular examination, head posture was normal, no facial asymmetry noted, eyes are orthophoric, and extraocular movements are full and free and are painless in both the eyes. Coming to the visual acuity in right eye and left eye, both eyes, 618 with pinhole, it was improving to 612. Color vision was 25 plate. Intraocular pressure was 18 mmHg. And coming to the anterior segment of both the eyes were within normal limits. Pupil was 3 mm and was round and reactive to light, no RAPD. Coming to the posterior segment, media was clear. Right eye disc was hyperemic with 360-degree blurring of margins. Disc was elevated and cup disc ratio could not be differentiated. Venous dilatation was seen in the right eye, whereas in the left eye, mild blurring of disc margins only in the nasal part was seen. Disc was hyperemic and the CDR was 0.3. AV ratio was 2:4 and F4 was plus in both the eyes. So by now we have the differential diagnosis of papilledema or neuroretinitis. Few were fitting in this case with the suggestive of papilledema and few were suggestive of neuroretinitis. So we proceeded with the other investigations like visual field analysis. In visual field analysis, both eye central scotoma was seen, and in right eye enlarged blind spot was seen, suggestive of disc edema. And we have done MRI for this patient, which showed caudal herniation of gliotic appearing cerebellar tonsils below the foramen magnum and mild supratentorial ventricular prominence, which was showed in the marked arrows. By this findings, we have this incidental finding of ulnar chiari malformation type 1. And then we have done the lumbar puncture in which opening pressure was 22 mmHg. CSF and cytology showed acellular smear. So this was our incidental finding. And then we have done a VEP for the patient, which showed prolonged latencies and which is suggestive of bilateral anterior visual pathway defect. So in summary, patient came with complaints of headache and visual disturbances for past 10 days. On examination, vision was 618 improving to 612 with normal color vision and no RAPD. Both eye had disc edema. Right eye was more than left eye. VP showed prolonged latencies, and MRI there is a caudal herniation of lyotic appearing cerebellar tonsils below the foramen magnum, which was suggestive of anal Chiari type 1. So in conclusion, careful clinical evaluation and fundus examination of relative investigations are essential in diagnosing the disc edema. So attention to history, visual assessment, color vision, pupil assessment, EOM, and visual field patterns help to avoid misdiagnosis. So the treatment given in our OPD was acetazolamide 250 mg TDS, triptomer, and methylpred for 3 days. Thank you. Thank you, sir.
Nice presentation. Now we invite Dr. Gautam to share your comments, please.
Very good presentation. Can you tell me the mechanism of papilledema in this case?
Sir, when the patient came, we thought it was intracranial hypertension was raised. Sir, it's because of raised intracranial hypertension. And after doing the lumbar puncture, the CSF pressure was 22 mmHg. So that might be because of, then we have done VEP, which showed prolonged latency. That might be, we thought of demyelinating disorders also. That's why we took the differential diagnosis of neuroretinitis, sir.
Okay, fine. Actually, the cerebellar tonsillar herniation can obstruct the CSF flow in this case.
Yes, sir.
In
Yes,
Chiari
sir.
malformations, usually the
Yes, sir.
cerebellar herniation can themselves obstruct this thing. That can lead to the raised intracranial pressure. Okay,
yes.
fine. Okay, thank you.
One more last question. Why I just saw the treatment protocol which you had given to the patient. So what
Yes,
was
sir.
the rationale of giving steroids in this patient?
Ma'am, we were treating, we would have this differential diagnosis of optic neuritis, ma'am. So we thought of starting ONTT regimen for the.
But you had already done an imaging and that was showing the
Yes,
herniation.
ma'am. Yes, ma'am, it was
So
showing.
what was the rationale?
Actually, after VEP, we thought of demyelinating disorder also, ma'am. We are sending MOG antibody testing also, ma'am. That hasn't been done yet.
Okay.
The result hasn't been out yet. So we thought of starting ONTT regimen before end itself.
I have a question. May I?
Yes, sure.
Yes, sir. Yes,
Yeah.
sir.
You mentioned there was already an herniation, right? But
Yes,
after
sir.
that, an LP was done, what I could understand.
Yes,
So,
sir.
as per my understanding, goes in cases where there is anal care malformation, be it type 1 or type 2, whichever. So, if there is a suspicious, like you can actually see some herniation and do an LP, it will aggravate the headache and it will actually cause aggravation of the symptoms. So,
Yes.
why was it done, especially when you are already suspecting based on the MRI?
Because other clinical findings were not correlating with the MRI findings, sir. The patient doesn't have any other symptoms other than headache, sir. So we thought of proceeding more with the investigations. That's why we have done VEP and MOG antibodies also, sir.
Okay, fine. Okay, thank you.
Thank you.
Can I ask one question? Last.
Yes, ma'am.
Yeah. Nice presentation. So I just want to ask, what was the cause for poor vision, like 6-12 in papilledema? Usually vision should not be low.
Yes, ma'am.
Color vision was normal in this case.
Yes, ma'am.
So what was the reason for 6-12 vision? And also P latencies were delayed in both the eyes. So what?
Ma'am, patient
What
is 50-year-old, ma'am, actually.
Was there any cataract which explains it?
No, ma'am, not fully immature cataract. The patient had early lens changes. That's it.
Oh, okay. Because did the patient improve after this IV steroids?
No, ma'am, not improving, ma'am. It's been 3
So
days.
because that 6-12 vision in both eyes is not explainable, though the color vision is normal and
Yes, ma'am, color vision is
actually
normal and no
according to
RAP.
VEP, according to VEP there are delayed latency, but even then like everything is not fitting into picture. And as Dr. Deepak had asked, like Arnold Chari malformation itself is a contraindication for LP. So it has to be done
Yes,
with
ma'am. LP.
caution because there can be brain herniation and all.
Yes, ma'am.
Okay, thank you.
Thank you.
Okay. Yeah, wonderful case presentation. We have a marathon of 30 cases and Fine.
You
Thanks
stop.
to our judges who are patiently scoring all of them. That is Dr. Deep, Dr. Gunjan, and Dr. Gautam. Dr. Deep and Dr. Gunjan were my batchmates. Thank you so much for accepting my request and being a judge for this competition and patiently evaluating all the cases for 3 hours. And thank you, Dr. Gautam, to come in the last moment and become a judge. And thank you, Dr. Ayushi and Dr. Shruti and Dr. Komasweta for being a panel and asking intellectual question, making the discussion engaging. Yeah, now I'll a few comments if you want from Dr. Deep or Dr. Gunjan or Dr. Gautam. Do you want to say anything?
Yes, thank you, Dr. Karthikeya, for giving such a good opportunity. It was a wonderful session, and there were many interesting cases also. It is all the hard work of your team that this case presentation series has reached to such a level that now even international participants have come this year. So very nice, and kudos to the team, and thank you for the opportunity.
Yeah, thank you, Karthikeyan. It has been a pleasure to be a part of Naadi since season 1, and it has been it's always interesting and fun to see our new residents from any of the institutes coming and presenting. And this time we got to see international residents as well. So it was a very good experience. Not just that, it was quite enlightening as well. There were so many different new cases. Yeah, that's it.
Good evening, everyone. It was a very nice learning experience with respect to the interesting cases for me, and also I got we got to know how patients are managed in different countries. It was also a very nice experience for us. Thank you for the opportunity.
Actually, one small tidbit is Dr. Gautam was a participant. He actually won the season 1 and then now he's become a judge. So that is how it turned tables for Dr. Gautam. It's a very intelligent case that he had presented.
Thank you.
Dr. Komasweta, any comments?
Yeah.
Meanwhile, Dr. Prasanna is making ready the certificates.
Once the
The
judges
master behind this all these certificates, program book, and inviting 15 countries, everything is because of Prasanna only. And all the scoring sheets and all these things are made by Dr. Pranesh. All the Excel sheets and all the the algorithm, everything was made by Dr. Pranesh. And Dr. Niranjan, he's the only one man. Because of him only we got the sponsor. The prices is not, we are not going to announce the prices now. It will be announced, it will be a suspense, will be announced on a valedictory ceremony with the presence of the chief guest after session 3. Panelist Dr. Komal Sweta, any comments please?
Yeah. Thank you, Dr. Karthik and YOSI team for giving this opportunity. It was really nice. There was a lot of cases, nice cases. It was a very good learning. Thank you.
Krishna, when can we have a group photo?
Yeah, one second, Karthi. Before we move to the group photo, so thank you everybody. We have this certificate distribution, which we very passionately do for all the events that we are part of, requesting all the participants to switch on your cameras. This Noinadi 3.0, as you can see in the slides, we have 15 countries. So again, a vision of Dr. Karthikeyan Mahalingam, who brought a group of 3 people 2.5, 3 years back, which we just showed before we started the event, and it was his vision that we all joined hands with him, diagnosing the illness, tracing its cause, seeking proper remedy, and apply it with skill. So that is what Noinadi is actually means. So that is something that we really wanted to emphasize. And this was the first capsule, as Pranesh was telling. That we had many winners of the previous capsules being part of the other side. We are proud to see Dr. Deep Shekhar Das, Dr. Gunjan. Again, she was one of the preliminary judges along with Dr. Deep Shekhar and a few of our other friends in the season 1 as well. So it feels nice to see such a homecoming or a full circle after 2.5, 3 years. A group of 3 people brought together by Dr. Karthi. And we had 30 participants in the first capsule, and we elaborated it and expanded it to another 35 participants in the second season as well. And you can see again Dr. Deep Shekhar and a few of our common friends, Dr. Shruti ma'am. They were all part of this journey where we were able to bring in Dr. Satyen sir, the president of GSI, and Nirmal sir for the last 2 capsules. So when we started season 3, we wanted to do something different because we felt going international is the way forward, as Dr. Devakant, our president, keeps telling. So, which we had YOSICON International 2 months back, and that is how we went. And so here we are. So thank you, Dr. Deep Shekhar Das, sir, for patiently being here with us, not only for this capsule, but also for the last multiple capsules of Naadi. Dr.
Thank you,
Gautam.
Dr. Prasanna. It has been a pleasure. It has
Thank
always
you,
been a
sir.
pleasure to be a part of Naadi, and it's always been
छे
enriched.
बहुत knowledgeable है वो chief guest वो.
Thank you, sir. Dr. Shifa, you are on unmute. Yeah. And Dr. Gautam, thank you for being here. Despite the short notice, less than 2-3 hours. So we wanted to honor your presence with the certificate, getting it ready quickly as well, just like how you got ready. So
Okay.
thank you.
And even he took a half-day leave to prepare for this competition. That shows his dedication.
Yeah. Thank you, Dr. Gautam. So we wanted to get your certificates prepared as well, as quick as you are. Thank you. And Dr. Gunjan, thank you. I was able to hear your child's voice as well, as that was your commitment. I think thank you for being here again, not only for this season, but uh, even the previous seasons. And thank you, Dr. Gunjan. And again,
Thank you for the point.
thank you. Thank you, Dr. Gunjan, for your commitment despite your newborn. And thank you for being here. And Shruti ma'am, again, thank you for being here. Dr. Koma ma'am, thank you, ma'am. Your discussions were very enlightening. I think many of us learned a lot, including us. Thank you for being with us with your insights, sharing your insights. Is Shruti ma'am here, Karthi?
No, I think she's not here.
Okay.
Madam told she's leaving, so.
Okay. Thank you, Koma ma'am, Koma Shweta ma'am.
Thank you all.
Dr. Aishi also has a flight to catch, I think.
Yeah, Aishi, despite your busy schedule, is Aishi here? Okay. So Aishi has really helped us in the background with many submissions from her residents, from her institute. So it's a team effort at the end of the day. With Karthi at lead, and we had multiple wings. Our executives have really helped us a lot. And Dr. Gunel and Dr. Aitan were from Azerbaijan. Dr. Saima was from Bangladesh. Dr. Butt was from Mongolia, and she's currently in Australia for the AOS International Conclave that is happening. And we can see the commitment of each individual. Dr. Shafiq from Pakistan, Dr. Niru from Sri Lanka, and our own Indian faculty, which I will hand it over to Dr. Pranesh to do the completion. So we had 5 countries, more than 5 countries, part of only day 1, and we have divided each days with five countries. I'm handing it over back to Pranesh to complete the
Thank you.
certificate distribution. Over
Thank you,
to
Prashna.
Pranesh for the
Thank
Indian
you,
country.
Prashna. Certified Dr. Simran for amazing case on choroidal melanoma. And Dr. Nyana Miga, excellent presentation. This presentation went over my head on organoid nevus syndrome. And then Dr. Nishant yes on enigma of unsolvable NSOID. This Niba Gupta on stitch and MCS9. Dr. Renuka for her presentation on retracted case. Dr. Ayushi for a presentation on middle canthal mass. Dr. Rahul VR for a presentation on drug reaction to fluoroquinolone. Dr. Mriganka Shankar, her presentation on swollen tooth of a patient with diabetes. For Rahul, for his presentation on Sjogren's. for Dr. Jani on presentation on uncovering and forcing diagnosis. For Dr. Jyotishri, a presentation on basal cell carcinoma. Dr. Nandita, her presentation on metastatic lung cancer and orbital apex. Dr. Angel, a presentation on. No, she didn't present. She's on day 3. So yeah. Dr. Shvetashri on eccentric proptosis. Dr. Tulika for mucocele. Tulika for mucocele or masquerade. Dr. Vaishali Bharti for a presentation on interlesion sclerotherapy. Dr. Shifa for a presentation on resilience from recurrence to resolution. Dr. Akanksha Valdia for a presentation on subarachnoid derived vitreous hemorrhage. Dr. Mogatala.
Not.
No. She was not. No, not that. No. Dr. Sahila.
Dr. Mogata.
She wasn't. Dr. Sahila for a presentation on reversible field loss, posterior circulation stroke. Dr. Neil Kavedia for his presentation on Graves in a 10-year-old.
I think
Anita also not that. Dr. Aparajita Shukla for a presentation on NF1 plexiform neuromyelin unveiling a novel mutation. So Dr. Nishita Sarva Reddy on a presentation on Arnold Chiari malformation. And that was also not that. So on the outside, I would also like to thank the judges because
Dr. Amrita was there, right?
She's on day 3.
Day 3. Okay, perfect. I think that brings us to the end. So thank you, Pranesh, as Karthi told, for all the technical help. The backdrop, Pranesh has worked very hard with timeless hours in all the technical modifications, the Excel sheet, the timer, the coordination. And again, this is a brainchild of Dr. Karthikeyan Mahalingam. He was the one who brought a group of 3 people, and now we are a group of 6 people together. That it was his vision that we all, came together. And currently we are working hard to take it globally. Every day, every year we have this one capsule of Naadi in YOSI. And now this has become a brand, and hopefully we'll keep continuing this globally as well. Thank you, and handing it back to Karthi for the closing comment, and requesting everybody to switch on the camera with the YOSI
group photo.
And we'll close it. Manjula ma'am, we can go off live.
Okay, doctor.
Yeah, we can go off live.